In session one, we discussed a common data model, why, and we already touched actually the other questions slightly which and how. But in session two, we will review in more details a number of models and many those that are used outside Europe, Sentinel, OMOP PCORnet, and we will discuss the challenges that they may have, especially in view of the European environment. So this is a rather long session, and so we would like to start immediately. And there are 6 speakers, and 5 speakers are with us this afternoon. One of them, Olaf Klungel, was not able to travel this morning, and therefore he will give his presentation by teleconference. So I propose that we start immediately, and we will start with a presentation by Jeff Brown on the overview of the Sentinel Common Data Model. Jeffrey Brown is Associate Professor in the Department of Population Medicine at Harvard Medical School. He is also Associate Director of the FDA Sentinel project, so he's really the right man at the right place. His primary research interests target the use of electronic health data to generate actionable evidence for decision making. So this is perfectly in the scope of this session, and so I welcome you, Jeffrey. Thank you.
You have your chair back. Thanks so much. All right, there's my clock. So thanks for the invite. It's really great to be here. I've been doing this for 12 years. I don't want to admit how many different data models that I've been part of. You'll probably see a list a little bit later. There's probably good reasons for them. And you'll see I have more slides than are appropriate. I'll keep to time, and I'll skip through some. I actually am speaking tomorrow a little bit about data validation, so I'll leave some of it to them. So I have some disclosures. I'm broadly funded, I suppose. So I'm going to start with the conclusion, which is, keeping the frame that I've been asked to speak really about Sentinel. I've been part of, as I mentioned, a bunch of data models. Lesley's going to talk about PCORnet. Lesley was part of the work in Sentinel. I've been part of the work in PCORnet, and others as well. But I'm trying to focus on Sentinel, and really what I'm trying to communicate are some of the lessons learned. Sometimes you think of them as some of the scars that we've faced over the last 8 or been subject to over the last 8 years or so, building the network that Michael so nicely described. But I'm going to start with really the summary. The model includes claims data, EHR data, and registry data. The biggest portion of the model are US commercial claims, but we also have incorporated EHR and other data into the model. It can incorporate data from other domains if it's there. I'll talk a little bit about how the model came to be, and really the summary of that is the model was designed, 1, for FDA's needs, and 2, with our data partners at the table. So it wasn't designed in a vacuum, but it was designed with the actual folks who had to do it with us. So when we wanted to do something and they said, I can't do that, it didn't enter the model, right? It was, maybe we can do it next time or we'll update it. So it wasn't designed in a vacuum, but very specifically for this purpose. The idea is that it should be able to support any kind of analysis because the data are simply stored at the granular level. I'll go through some guiding principles that describe this. It had to meet FDA's needs for flexibility. It was designed to meet those analytic needs, flexibility that Michael described. It's this distributed querying approach, which is important when you're designing the model. How you're going to do the analytics, and we were forced to do as much of the analytics at the node or at our partners as possible. And the idea is, as Michael also mentioned, giving FDA maximum control of the network, the data, and the tools. Nothing changes unless FDA wants it to change, and that's actually really important when you're a regulator to not have things change without your knowledge or without your control, right? So we know the kinds of data that exist. I'll point out there's patient-generated data. We're just finishing a mobile app project, collecting data through mobile apps, which worked out better than I expected, so we're kind of excited about that. We'll see where that goes. It's really nice to go after after Michael and Patrick, who described this, I can say they already said it. The data models are designed for different purposes. Really, Sentinel is looking for information about groups versus a health information exchange, which is a different structure, and we won't be talking about it. The idea when you're doing these kinds of networks, I might refer to them as distributed network. You're either going to translate the data or you're going to translate the query. When you're translating the data, that's this common data model approach. When you're translating a query, that's this common protocol approach, where you're translating the protocol to the data. So there's really two approaches, but the networks that we'll be talking about have really translated the data. Excuse me. So going back pretty far, these are just some that I've worked on. And at some level, I feel bad of having so many different data models, but they were for different purposes. Sentinel is actually the basis for these at the bottom. This is actually chronologic. Is actually the basis for all of these other activities, which kind of gets back to one of Michael's earlier points, which was FDA was building this resource, really supported other uses of it. So have been helping or really promoting, cheering us trying to figure out other ways of using that same resource for other purposes. So the Sentinel, FDA Sentinel overview, actually I have a pretty nice website now. It's gotten a lot better, so I encourage you to go take a look. All the reports, there's pages and pages of the reports there posted, protocols posted. It's actually, I think it's turned out really nice. Our partnership, the way we're organized, and we'll probably talk about governance tomorrow, I think, it's a contract. So this is a contract with the FDA to Harvard Pilgrim Healthcare Institute, which is where I sit. We have a set of subcontracts directly with our data and scientific partners. You can see the middle layer here are the data and scientific partners. It's important that they report to us. We're contracted directly with them. If FDA is not happy with something going on there, they have one person to report to. If it doesn't work well, it comes back to our desk. The structure actually is important that it's organized this way. I'll point out just two things here. You'll see Kaiser Permanente there. That's an integrated delivery system, right? So that's claims data and EHR data together. They actually are taking information from both systems. The same for the Healthcare Systems Research Network folks. And Hospital Corporation of America is really a new addition. That's a hospital system in the US. It's about 160 hospitals across the US, all EHR based. So one of the things you'll see when I show the model is we extended the model to take better use of the data that Hospital Corporation of America has that the other partners don't. So the model can expand in that way, and you should expect that. I think that's a good thing. It's a big data resource. We like to think about it in person years versus people. 425 million person years, 43 million current accruing, and right around 40 million kind of with lab results. But think it's pretty big, but it's distributed. So how did this come to be? I guess I was one of the few folks there in the beginning. You win the contract, yay. Now we got to get to work, and how do we do that? We called Lesley and to help, and we called a bunch of other folks, and we got our data partners together to go about designing the model. What are the models? Typically, it's really information about people, care, and then maybe patient-reported information. Apologies, I'm going to skip over some slides pretty quick. You can have the slides. We can share them. So how did we start? We started by talking to FDA. What do you actually need to do? What are your real goals? What are your top 5 kinds of things? Is it speed? Is it validity? Is it sensitivity analysis? What is it that you really need? What are the kinds of things? And then we'll go from there. When we built the model, it was with our partners in the room. So we actually started with a previous model, took that as the starting point, and then went from there. We came up with a final version, we used it, and then we've been iterating ever since. So you implement it, you data check it, and you can see now we're on version 6 of the model. So Michael described the anticipated uses, so I'm going to skip this. He described what he's doing. The model focuses really on comparable format and definition, and then curation. So the format and the definition should be similar across the partners, and it has to be well curated. I'm going to talk about the curation really tomorrow. We have, I should know this, I think it's 12 guiding principles. These were put together before the model. And this was a lot of input from both FDA and our partners. It had to accommodate, obviously, FDA's current needs. It had to be able to handle new data types. We kept the model relatively parsimonious in the beginning and then expanded. That was on purpose. Interpretation, we acknowledge, really required the engagement of the folks who know the data best, which are those who are holding those data. We understood that there would be site-specific variability. That's okay. We just wanted to know about it. This was important that the design had to be intuitive and easily understood by the epidemiologist. So it was by the person at FDA, by the investigator. They had to be able to look at it and understand it. That was important as we were doing this. But interoperability was actually pretty straightforward. We also wanted to make sure that the data elements in the model represented what was in the source data every time we could. And you can really do that almost every time. There's a couple places where you can't, but the idea is we don't map any of the data elements if we don't need to. So we'll get into probably over the next 24 hours conversation about mapping coding terminologies, which may or may not be important here, but it's not something we do. We also don't create derived variables or derived tables. What I mean by that is if you can generate that information from the information in the model, generate it at execution and don't pre-populate it. That was actually, I think it's an important concept. It was actually a demand of our partners. They didn't want us to do that. It's just a waste of space for them because you can generate that information at execution. A times B is equal to C. If A and B are in the model, don't create a variable C because you can do that whenever you want. That's the idea. This actually came from our partners as well. Distinct types of data should be kept separate. Part of this was to protect ourselves from misinterpretation. So medications and prescriptions, so a medication dispensing and a medication prescribed and a medication administered are different concepts. One of the reasons we wanted to keep them separate was that the data are actually refreshed at different frequencies in their source systems. So there are scenarios where that would cause trouble if we wanted to do something rapid. So we would be in a situation where the timing in that same table could be off, and that would be trouble. But so we kept these things different. Another reason we kept them different was actually to protect user error. We didn't want people to confuse themselves, even though they would obviously be flagged, and the other models just flagged them and should be able to handle it just fine. We were just kind of protecting it from our own errors, I suppose. And you can see the rest of these. We have this certainly an important construct of minimum necessary. So we don't share, we only share what's absolutely necessary for the analysis. I'm just going to throw the model up here. Pretty straightforward. It is claims-based plus EHR is how to think about it. You can see on the left the clinical data that's coming from our EHRs. We've added registry information. And then on the right, that there's inpatient, that's that Hospital Corporation of America data that they had, no one else actually had available. Or the Kaisers are starting to pull this information in, we hope, but that's the idea of just extending the model in that way. So what does a patient look like? This is getting at this idea of transparency. This is actually what the data look like. It's pretty simple. It's obviously not all the variables, but the idea here is if you have the model, if you have the data model and the database, you should be able to know what's going on. So F is equal to female, and N is equal to no, and race is 5. Now, race is one of those things that you had to map because of the way it's collected in the source systems. But that's the idea. So it's a diagnosis, it's an inpatient, it's an ICD-9 code, it's a secondary. So if you have those two pieces of information, meaning the model and the database, if someone printed it out, you could read it. So that was the idea, and this is the same for procedures, right? No, we did it that way because we wanted the users to have an easy way of understanding what the data will look like. In the concept of, to support kind of the lessons learned, time-dependent information's kind of a pain. So your primary care provider changes, your primary care location changes, where you live changes, and if you don't capture that flag of when it's valid, the data become difficult to use. So without this idea of an anchor date, insurance benefit design, medical versus drug is one of these concepts. You'll see this last comment. If you don't understand how that design changed, if someone has, for example, drug coverage and no medical coverage, they'll never have an outcome. And if you don't understand that, you can run into trouble. So if the model can't handle it, you can run into kinds of trouble. So this is this idea of, just a quick idea mentioning of the difference between the claims and the EHR. Claims data, person time, for the epidemiologist in the room, it's pretty easy to define. In EHR data, it's much more difficult to define when you start and stop observing someone's time, right? So when in an EHR system, it's just hard, you have to come up with essentially some definition, and you either have to hard code it or you do it at analysis to figure out when you don't see something, is it really because it didn't happen or it happened somewhere else, is actually very difficult to see in an EHR system. So you just have to come up with a way. So medication exposures, I have a couple slides I'll go through quick, looking at the time. The idea here is, I mentioned that we don't have to commingle. You don't commingle, and you keep the table pretty parsimonious. If you're thinking about adding, so this is the construct of how we've added information over time. This is an example. If you wanted to, this is what the table looks like now. These are values. When you want to add a new value set, so you want to add a value set from the EU, basically just add it to the model. So why wasn't a read code in there? Actually, SNOMED codes weren't in there in the beginning. The reason why SNOMED codes weren't in the model is because 0 of our data partners had any SNOMED codes. So it would have just been 0. Now, really no one has SNOMED codes now either, but we added it. There might be a couple that come through. But that's this distinction between designing the model in a vacuum or designing the model with your partners in mind. So there was no need for it to be there, so it wasn't. We did put ICD-11 in, because it was easy enough. Someone wrote 9 and then 10. We wrote 10 in the beginning, so we wrote 11. But it doesn't change the nature of the data. Some key considerations when you're thinking about when you're thinking about data. Just because the variable's there doesn't mean it's complete, doesn't mean you can use it. It might be a lot of variability over time, even within partners over time. Having data information in one source system doesn't mean you could standardize it and make it usable. Standardization really is this ongoing process, and really it's every change to the model is now very clearly directed by FDA. There can be no surprises there. Excuse me, I'm going to skip my data validation stuff because I'm going to talk about it tomorrow morning. The point being, as Michael mentioned, every time our partners refresh their data, I should make a point of this. This isn't a static database. Every quarter, most of the data is updated, and it's updated at different times. So there's one this month, one next month, there might be 3 next month. So the data are actually always changing, and they always have to be checked. Every time, we don't use a data source unless it's been checked. So we actually approve it, then allow them to use it, and we have software tools that make sure that they can't use the old one, or they can't use a new one that we haven't approved. It won't run unless we've approved it. I'm going to skip what's next. I wanted to get to this idea of distributed analysis just because I haven't seen actually how it's going to work in these networks. Just to describe how we do this, we actually use a piece of software called PopMedNet. Conflict, I'm the inventor of PopMedNet. It's an open source software, but we built it ourselves because there was a need here. So we actually we log into this website, distribute the queries out to our partners. They run it locally. They send it back to this secure website. Then we download it and create the result. So this is just this speaks to security in the network. I just haven't heard us talking about that here, so wanted to mention that we're sending, this is personal health information, so it's kind of important how we handle it. To get at, in the last couple minutes, standardized analysis. So both Michael and Patrick really nicely kind of described there's data, there's the data model, then there's checking the data, so a data curation, and then it's all because we want an answer, right? This is all to build towards, can we use tools? So the only reason you would do a model is if you're gonna build some tools. So a typical project, this is the old version, you hand code it, this is the one-off protocol based. If it's reusable, you think of all of the parameters that are just gonna be different this time. And then you build an analytic infrastructure that's reusable. So think of tools. That's the idea as you're building these tools. So Michael mentioned this kind of set of tools. We think of it as kind of descriptive to inferential, and we built tools to do them, and they're all built on top of each other, essentially, in how you think about it. So it's a toolbox. We have a set of things. Now, why this set of things? These were the things that were most important to start with. It will keep growing, right? As we started with a propensity score design, then we added a self-controlled design, and then we have a drug use and pregnancy tool, which is new within the last year or so. Why? Because that question kept coming up, and it was a very different kind of question, so we wanted to build something specific to address that. And then, you know, the font will get smaller and the list will get longer, I suppose is how it'll go. That's what we hope. So I'm gonna skip through some of these. Michael really mentioned this idea of analytic flexibility. These analyses, the analyses that we've been doing for FDA really have been customizable. There are things that FDA has asked for that I've never thought of, but they make perfect sense. One of them is kind of the stockpiling algorithms and how many different ways you can coordinate or use exposures over time. So dispensing, how do you create a treatment episode? It can get really complicated really fast. So we kept adding on to the complexity to give more flexibility to the tools, essentially. So you can think of it as stockpiling. That's how we create the exposure. So here's a little bit of information on the stockpiling. Again, you'll have the slides. Then these episode gaps, well, there's not a single answer to this. And we went back and looked, and there's a pretty wide mix of use of these parameter settings, which so you can't assume that one's going to work. So we've been using 7, 14, 30. Sometimes we use 3. It depends on the product. It depends on the need. It depends on what you're doing. What's nice about the tools is that you can, if you'd like, try 7 days, 10 days, and 15 days, and just look at you don't want to look at the outcome. You just want to look at, does that change how much exposure you're really getting? Is it an important parameter or not? And then you can go on. And then you've got your outcome definitions. You have to be able to be flexible enough. So I hope we talk about this in the next day or two about, is there a standard definition of VTE, or are there a lot of definitions for VTE or diabetes or whatever that outcome might be? We have not been in the space where the old definition is really going to be used in the new analysis. You want to have a nice way of knowing what's been used, so you might base your new definition on it, but I haven't seen one definition of diabetes. I've seen 30, and they're all perfectly right. They're fine for that use. So that's the way we've designed it, because that was the assumption. So I'm ending here. On the left, I'm just trying to describe some of these collaborations. I think this is incredibly important. I guess I should have put the EMA logo. Right. No, next time. So on the left side are actually folks who are trying to have adopted the model or used it. PCORnet and Healthcare Systems Research, we try to collaborate closely because we have so many overlapping partners. And then we've been talking a lot with other agencies who have really just kind of either come to Boston or we've gone there to describe what we've been doing. Not necessarily with the model, it could be with just the design of a network. But they are building these kinds of versions of Sentinel across the world, so we're happy to be collaborating and happy to be here for it. I ended with my summary, so there we go. Thanks.
Thank you, Jeff, for this excellent and very useful presentation on guiding principles and tools using Sentinel. I think is extremely useful to progress on these reflection on common data models. Now, the following presentation will discuss on the challenges that may exist in applying the Sentinel Common Data Model to electronic medical records with the example of PCORnet. And this presentation will be given by Lesley Curtis, who is a professor in medicine at Duke University, and she is also an expert in the use of medical claims data for health services and clinical outcomes research. She has a lot of activities, but among them, she serves as co-lead of the data core for the FDA Sentinel initiatives, and she is a core principal investigator and lead of the Distributed Research Network Operations Center, the PCORnet network. And Lesley, I give you the floor. Thank you.
Thank you so much. It's a real pleasure to be here, and I thank you for including PCORI and PCORnet in this meeting. So today I want to touch on three items. The first is to give everyone just a really brief overview of PCORnet, which may be familiar to some folks in the room, but probably not to all. And then I'll touch on the data strategy, the PCORnet data strategy, and as the title suggests, I'll also touch on some of our experience to date in applying essentially a Sentinel-based common data model to electronic health records. PCORnet is a short version of the National Patient-Centered Clinical Research Network, which really was the signature investment of the Patient-Centered Outcomes Research Institute. Those of you who may be familiar with the U.S. healthcare market and certainly the U.S. federal government, when the Affordable Care Act was passed, it levied a tax on health plans, and that tax, some of that tax was funneled into the Patient-Centered Outcomes Research Institute for the specific purpose of generating evidence about what works best for patients. PCORI had quite a bit of money in its coffers from that tax, and decided to invest in standing up a national clinical research network, modeled largely, I would say, after the success of Sentinel and FDA's success with that. They very much wanted to achieve similar results, but incorporate electronic health record data from around the network. I'll talk a little bit more about that, really to enable very large-scale clinical research, both interventional studies with randomization and observational studies. Now, PCORnet is a network of networks. There are 20 patient-powered research networks that are part of PCORnet, and those patient-powered research networks range from, I would say, organized groups of patients around a specific disease or condition, to very sophisticated registries of patients, also connected to those patients, and the patients are involved, but very sophisticated data platforms and registries. The 13 clinical data research networks really are the networks that I'm speaking most about when I talk to you today. In the initial PCORnet application process, they invited clinical data research networks to come forward that covered at least 1 million individual patients and included at least 2 or more major health systems in the US. So these networks that came forward were networks of health systems, essentially. Many of them organized around a geographic construct. So we have a clinical data research network that's based in New York City. We have one that is and includes several health systems within New York City. We have another one on the other coast that includes several health systems in the University of California system, if you will, and then other networks in other regions of the country. There is a coordinating center in the middle of all of this that includes not just Duke, but Harvard Pilgrim, where Jeff and his team sit, and Genetic Alliance, which is based in Washington, D.C. Oh, I forgot our 2 health plan research networks. I skipped right over that part of the equation. Humana and Health Corps, 2 large health plans in the US, are also part of PCORnet. And this equation adds up to PCORnet. What that means is that PCORnet, when we think about it, it's not just based in one area. It actually covers the entire US. There are partners in the network representing each state in the US. Okay, so that was the overview of PCORnet. Let me turn now to the data strategy that we've taken. Now, PCORnet began in earnest about 3.5 years ago, if I'm doing my math correctly, and we began with the realization that a common data model would be absolutely essential to the work that we had intended to do. So I'll talk in a minute about our approach to that. We also recognized the need for a real focus on data quality and data curation. I think I might not have mentioned the number of distinct health systems that are represented in PCORnet. That is 79. Sometimes we add it up and it's closer to 85, but I'm going to use 79 today. That is a lot of health systems, and I will tell you that is a lot of heterogeneity. So we recognized that data curation and a real emphasis on data quality would be important. I'm not going to talk about the secure distributed query infrastructure that we used because Jeff so kindly put up a nice picture that showed what we use. It is the POP MedNet. And then we recognized that we weren't going to be perfect right out of the gate. And the only way that this network and the network would evolve to meet the needs of PCORI and to be part of this national evidence generation system that is envisioned would be by us learning, doing, and then repeating and iterating toward improvement over time. We began with a set of guiding principles, and I'm going to walk through these. Jeff has actually touched on several of them, and that's important because we began with the Sentinel Common Data Model guiding principles, I would say as a frame, as a straw person to begin the conversation. And then with our partners from these health systems, with their electronic health record data, said, let's get rid of those that don't make sense for EHR, right? Keep only the ones that make sense for the kind of data that we're talking about. And I think what you'll see is that we arrived at a set that are actually quite similar to the guiding principles that really underlie Sentinel. We said the common data model has to include data that are of interest to PCORnet and to the work that PCORnet intends to do. So keep in mind, this is both observational studies, these are both observational studies and interventional studies. And that those interventional studies require that we get back to individual patients who may be asked to consent to participate in those studies. This is a network of nearly 80 health systems and many, many people involved actively in the work. So we said the common data model has to be something that people all around the network can understand. And when those individual networks within PCORnet decide to use the common data model to do a study, they should be able to pull that common data model up and know how they can use it to answer their questions. We recognized that other common data models exist and promised to learn from them, learn from what they had done well, learn from where they maybe had some missteps or where they'd faced some barriers. So we explicitly brought Sentinel and OMOP and I2B2 to the table and said, okay, given what we're trying to do, where do we pull from? How do we do this? Related to the second bullet point, we were fairly fairly certain that the common data model needed to reflect values that are found in the source data. Jeff talked about this in his presentation, and that really gets to both this issue that Patrick raised of the burden on the data management team to do extensive mapping, and also the point that Jeff made, and that is the loss of, I would say, the loss of information, the loss of local knowledge about those data as they make their way through a mapping process. So we wanted to be able, when an issue arose, to call the data management person in one of those 85 health or 79 health systems and ask them, what's up with this? What's up with this element? And not have them say, I don't know, we mapped it. You know, you'll have to figure that out. It was mapped into something. It wasn't me. So really to make sure that we have that enables, I think, a very deep dialogue with the local experts of these data. We also recognized and had as a guiding principle that the common data model will change over time. And this one, you know, telling your funder that we're not going to, whatever we come up with is not the only thing we will ever do with a common data model was both reassuring to them, because it meant that it didn't have to be complete and perfect the first time. But it also made them a little bit nervous because they kind of wanted it to just be a static data model and then we'd be done with that. But I think we all recognize the need for this continual evolution. And then finally, we recognized that not all networks would be able to populate everything in the data model, and that some might have other kinds of data that they'd want to be able to add to the data model. So we had to be able to address both of those needs. We've been very, I think, careful about those tables that we require be populated, and we've also been very open to partners around the network adding additional data domains to their version of the common data model. I show you this not because I expect that you can read it, because I know you can't, but to show you that we are now on version 4 of the PCORnet Common Data Model. That's a lot of versions in 3.5 years. So we've held to our promise to iterate over time as we learn. Importantly, the version 4 of the Common Data Model adds a couple of domains that were missing prior. One is around medication administration. Between our dispensing table and our prescribing table, we realized that there is a whole other data generation process within health systems related to medication administration, and a lot of that happens on the inpatient side. So we now, in the data model, have a way to represent that. We'll see how that's populated. Our experience is that anything new to the data model takes time before it is well populated and certainly well understood. We've also continued our commitment to make sure that our partners have a place to put data that they think will be useful for their purposes without creating any problems in the model. So we've added those tables as well. Now, I mentioned that data curation is a key part of our data strategy, and that begins with the network partner actually planning to refresh their data mart, which they do currently. All of them do it twice a year. We are moving toward quarterly refreshes, and for those who want to participate in interventional studies, randomized trials, they'll be required to do monthly refreshes for many of the trials. They plan their refresh. We actually at the coordinating center provide a data curation package that they download and run. We're not quite at 1,200 data checks, but we have a lot of data checks that we do, again, learning from other data curation activities that have happened in other networks with other data models, so that our partners can run that code, see where their version of their data mart, where it deviates from the common data model, and where those are acceptable. They respond to the query, there's review and dialogue with the coordinating center, and eventually the data mart is approved. I cannot underscore enough the importance of that curation process with every refresh, because things happen all the time. The source data are highly dynamic. If you can be highly dynamic, they are. And all of a sudden, programs that perfectly generated data mart according to the common data model specifications break for no reason. And it's because somewhere along the way something changed, and that change was not recognized or pushed forward into the code that populates the data model. As I was watching the weather last night, and I saw one of those weather maps that only appear on UK television, I realized that my learning with PCORnet, within PCORnet, looks like one of those weather maps. But the point here is that everything that we do informs everything else. So the common data model, and I'll touch on this more in a minute, but the common data model evolves based on what we learn by doing prep to research queries, for sure, but by the work we do answering questions as part of studies. Those studies are informed by the common data model, and it really is a very, I would say, connected and also complicated cycle of iteration. Now, in the time I have left, I just want to touch on what I would say are the key learnings that we've had from applying a Sentinel-based, Sentinel-adapted common data model to electronic health records. Electronic health records are highly heterogeneous, and the source data are dynamic. We've heard that before. For those of you who may think, well, in the US, there are a couple of electronic health record providers, Epic and Cerner, and most of these health systems use one of those. Therefore, when we're talking about heterogeneity, we're talking about a couple of different versions of an electronic health record. And I am here to tell you that could not be farther from the truth. Within my own institution at Duke University, the Duke University Health System, up until recently, we had different electronic health records at different clinics within the system. Whenever one of these electronic health records is implemented, all sorts of customization takes place, including customization about what value sets will we use, right? Things that most of us think should not be customizable, but in fact, they are, and they're more tuned to the process of generating bills for reimbursement than they are for capturing accurately and in a detailed way the care and outcomes associated with that care. Our takeaway from this is that when you are using a common data model, implementation guidance will always be necessary. With every table in the common data model, maybe not quite with every data element, but with every table, questions have arisen about how exactly do I do this? How exactly do I implement this part of the data model given the heterogeneity I see in my data? What we take that information, we basically take it and then create guidance around implementation. Guidance because there may be other systems within the network for whom that guidance doesn't quite apply, or there may be reasons why they can't fully follow that guidance, and we allow that kind of variability. But we've come to appreciate the need to really spell out what is expected. I've already touched on the importance of active data curation, and here we'll just show a slide. It's I've taken off the networks so that they're not being shown, and all that you need to know is 100%. In this case, 100% is not good; it's bad, and it's telling us this was on our third or fourth data curation activity. So this is not just the fourth time through, because many of them have done some off-cycle curation activities as well. So we're a few years into this, and we still find that there may be some basic issues in the common data model, the data marts that have been stood up across the sites. They're going way down over time. We still find that sometimes things are missing, and sometimes those things were not missing with the last refresh, but they are missing in this refresh. And so that constant attention is critical. I haven't mentioned it. We do ask when the data marts are refreshed and when the partners go through the data curation cycle, we ask them to provide us with an annotated data dictionary alongside that gives us information at a data element level about how they did that extract, transform, and load process to get from their source data into the common data model format. And that's a rich source of information for us, but sometimes we don't get those back. So people, we called that out as well. The good news is that the very top line that you see tells us how many of our partners and networks were approved by the deadline that we set, and that is so much better than it was a few years ago. So there's real improvement there. Patrick made this point, Jeff made this point. It is the tools and processes that make the data model both usable and useful. Sometimes I think probably the three of us have, I'm thinking over a beer, said, like, we talk all about the common data model, but that's not it. It's how you use it. What are the tools? What are the processes around that? And does that get you to your end goal? So it's the same whether you're using a data model atop a claims data environment or whether you're using it atop an electronic health record environment. Again, the data curation is critical, having something that is reproducible, that is predictable for the partners, and the analytical tools are critical. And we have developed some menu-driven queries that sit atop this data model in PCORnet, some modular programs, PCORnet modular programs that leverage some of the great work that was done in Sentinel, designing programs that can be reused. So we've done that. We're adding to our library of programs as we go along. I touched on this at the beginning. It is a guarantee that the common data model will evolve and needs to evolve to meet the new needs of the network. And the refinements are based on data curation and based on what we learn. I think in particular about a couple of examples with laboratory data and medication data, where in the electronic health record, we see a level of granularity that we almost never see in claims data. And our only approach to dealing with that has been through the data curation process, through the studies that we're actually doing atop PCORnet, where we see the variability, we see how things are coded differently, and then we fine-tune the implementation guidance, we fine-tune the data model so that over time we have a more standard representation of everything across the data model, using standard terminologies, using standard value sets where they exist, and refining over time. And I'm going to wrap up now and just talk about the importance of understanding how changes to the data model, which seem like a very obvious thing to do, how they create downstream impacts. And again, it's hard to read this slide, I realize, but the point here is that it's not just about creating the data model or refining the data model and implementation guidance. That leads to a necessary refinement and update of the data curation tools, that entire package. It requires that all of the analytic tools be updated, and most importantly, for all of those network partners, it requires that they update their extract, transform, and load processes. So while we recognize the importance of refining and evolving the data model over time, we're also highly cognizant of what that means for our partners around the network and certainly for those of us who are developing tools. And I thank you for your time and attention.
Thank you. Again, these guiding principles for very rigorous application and use and development of common data models are extremely useful, and we will certainly have the time to rediscuss them and this afternoon, but also tomorrow in the breakout session, because this is really at the core of the discussion that we will need to have on the use of common data models. We had in session one some first presentations on the OMOP data model and Odyssey, and we will now go into more details about OMOP. And I'm glad to welcome Peter Rijnbeek, who is actually an electrical engineer and also a computer program developer. He is currently assistant professor at the Erasmus University Medical Center in Rotterdam in the pharmacoepidemiology group of the Department of Medical Informatics. He's the project leader of remote research environment Octopus, and also he leads on the development of the Jerboa software that has been used, as you may know, in several European FP7 projects. He's also involved in the EMIF project and in Odyssey. So, Peter, I'm glad to welcome you in order to speak about OMOP.
Thank you very much for giving me the opportunity to speak about something that's very deep to my heart and something that I, over the last years, have appreciated much and much more. I think we all agree that this meeting is actually not really about which common data model we are going to pick, because we can all change the common data model and adapt it to our questions and our use cases. We also all agree that we should do good quality control on the ETL processes, and that's something nobody is disagreeing about. And it's not about whether you have 1,000 or 2,000 checks. We can all build in those checks against our models. What for me is really the most important thing is actually the whole community that is around that common data model and those tools. And I always, when I do a presentation about the OMOP CDM or Odyssey, I always start with this specific slide. And that is because I think this is the core of what we are trying to do here. And that is, in the end, we want to promote better health and decision and better care. But what I really like about this mission statement from Odyssey is that it also mentioned that it wants to empower a community to collaboratively generate the evidence. And that's something that over the last couple of years was really amazing to be part of. As you see how big Odyssey is growing, how many people are joining all the meetings that we have, the yearly meetings in Washington, for example, with more than 400 people all over the world contributing to the OMOP CDM and the whole community. That's really, really amazing. The objectives of the Odyssey initiative, I think it's good to briefly go through them. Of course, we want to be innovative. We really want to build good methods on top of the CDM. And that's, of course, starting from the OMOP project itself, but it's continuing in Odyssey with a lot of different working groups that we have established. Reproducibility is something that Patrick talked about earlier today, is at our core. So we want to develop tools that are open source, processes that are open source, the CDM itself that's open source that everybody can implement, can download from the website and run locally. The community aspect is crucial because all the development of the CDM and also the use of the vocabularies is driven by the community and the use cases that we encounter in our daily work. Collaboration is then connected to that. Openness, we want to share all the analytical codes that we create in the different working groups, and it's all on the GitHub of Odyssey. I like to briefly show you this slide because it's actually the core of the problem that we encounter. We have many different databases with different structures. This is an example of 4 real databases which actually capture exactly the same information, but it's just structured differently in these tables. What's interesting to see is that not one table name is the same in these different data models. Not one variable is the same name. Different table structures, some are rows, some are column-based. Also, interestingly, different ICD-9 conventions. So there's a dot or not a dot in those cells, which makes our life difficult because we have to query the data and then we have to figure out what the conventions were. And we like to solve that problem. So for example, within EMA, I can imagine you have 3 databases, but each of them have different structures, and you have to build 3 different analytical procedures to search in the databases. So what we do, and what we all do with our common data approaches, is that we try to standardize those different structures into one common structure. So there is actually no information loss going from the left side of the figure to the right side of the figure. We just structure the data differently. What's also important is that we want to find a way to standardize the coding systems that we use. And we all know in Europe that's a big problem. We have many different coding systems for all the different domains that we work with. And we like to find a way to make that easier to search in the databases using standardized vocabularies. So what we also know is that some of the codes are used, the same code is used in different coding systems, and we want to avoid that, we want to remove that ambiguity by doing standardization to a standardized vocabulary. And I'll come back to that later because I think that's one of the core things that needs to be understood after my presentation. The Odyssey community is really a global community, and that's something that is growing very fast. So it's not only in US, it's really all over the world at the moment. Europe's also growing very fast, and I'll come back to that a little bit later on in my presentation. There are more than 82 different databases across the world standardized to the OMOP CDM and using the vocabularies. A lot of patients, also more than 100 million patients outside of the US, which I think is a big strength also for the Common Data Model. It's a very multidisciplinary team of people. It says here more than 200. It's really growing very fast. All across the world, and different countries are participating. There are different chapters of Odyssey, one in US, one in Asia, and also a new one in Europe. The objectives of the Common Data Model are on this slide. We want to have a model for both administrative claims and electronic health record data, claims from private and public partners, captured at the point of care, etc. EHR data, and also registry data is being put into the CDM. What's important is that the aim of Odyssey is not a focus only on safety research. It's a very broad set of use cases that we want to be able to do in Odyssey and using the Common Data Model. So we want to use different sources from outside US as well. The model, of course, should be manageable for both the data owners and the data users. And we want to structure we want to standardize the structure, content, and with an analytical focus of specific use cases. What's important to understand is that the OMOP CDM is not only a fixed structure, but it's, as we call it, an information model. So it tries to standardize both the vocabularies, the conceptual model, as well as the data model. And so those two are blended. We also have the concepts are domain-oriented, so it's very clear from the vocabulary where each of the elements belong in the CDM, and I'll show that later when I share the model itself. It's patient-centric. It can accommodate data from various sources, and what's very important, it also preserves the data provenance, so you can store where the data comes from and also what the source values were. And of course, as I mentioned in the beginning, the OMOP CDM is also extendable, and it's evolving over time. If you look at this figure, you see the evolution of the model over the years. Each of the different changes in the model was driven by a specific use case. So it started with drug safety surveillance, but then because we added comparative effectiveness research, some changes were made in the model, and that over time the model is adapting to the use cases. What's interesting though is that in the last couple of years it's pretty stable. There's not a lot of changes in the model. So this figure shows you the OMOP CDM, with on the left side the standardized clinical data. So on the left side is all the clinical information stored in tables. And as I mentioned, it's a person-centric model, means that all of the individual tables link up to the person table that you see on the left side. On the right side, it's the standardized vocabularies. And there all the terminology systems are stored, and I'm going to dive a little bit deeper in that because I think that's very important and a thing that really distinguish the OMOP approach from other approaches. On the bottom, in the purple block, we see the standardized derived elements. So in these tables, you do see, for example, drug eras using indeed a standard 30-day gap, but nothing is withholding you to do differently and to do on an analytical step, define your own approaches for eras, doing stockpiling or whatever you think is needed. It also contains cohorts, and I'll show you later why we use those. I think what's very important is that each of the papers that we write contain a lot of concepts. So for example, cardiovascular, bleeding, drug information, and we need to have a common language to understand these terms and to translate them to our own databases and to extract the information from our databases using a standardized vocabulary. So in OMOP, we built a standardized vocabulary, which is a compilation of available terminology systems across the world. So it's not that OMOP is inventing their own vocabularies, but it's putting them together in a very structured way to allow us to do very fast and easy analytical steps. It's built on the shoulders of the UMLS, and we have added a couple of OMOP-grown concepts mainly for types, but overall, I think 99% of the standardized vocabularies is taken from others. So what is not? It's not a static data set. So the vocabulary updates regularly, and that's not because we at Odyssey are making changes in the vocabulary, but it's mainly because all those source vocabularies are changing over time as well, and we incorporate those changes in the standardized vocabularies. So it's also not a finished product. It evolves over time, also based on input from our community. What is very important is that we combine all the different terminology systems in one big table, the concept table, which contains about 78 vocabularies across many different domains. So why is this so useful? Because each of the individual terminology systems have their own data structure as well. So if we would like to use those different data structures, that would make our analytical steps quite difficult. What we do in the concept table is that we normalize all those different terminology systems into one big concept table, which allows us to standardize our queries using this table. So what is a concept? A concept has a concept ID. That's just used for in the CDM. It has a name, of course, atrial fibrillation is here an example. and it belongs to a certain domain. So in this case, atrial fibrillation is part of the condition domain. And it's using the SNOMED standardized vocabularies for this domain. It's a clinical finding, and it's a standard concept, which means that this is a concept that we map to from our source vocabularies. It also contains the original SNOMED code and a valid start date and end date in which this concept was valid over time. So how do we use that information? So each of the domains follow a standard convention. So there is in each of the table a person ID that of course refers to the person table. There's also a unique domain identifier for storing that specific line of data in that table. So for example, condition occurrence, in the condition occurrence table, each line has its own ID. What's very important is that we standardize each of the local terminology system to a standard code, which is denoted here by underscore concept ID. For example, condition concept ID is a unique identifier for that specific disease in the standardized vocabulary. However, that doesn't mean, and that's a misunderstanding I hear very often, that we lose all the information of the source vocabularies, which is not true. So we store in these couple of fields that you see here, we still store, for example, the ICD-9 code, both as a code and as a verbatim text. So if you decided to not include your dot, it will also not be in this field here. So we are not doing a one-time mapping and losing all the information on the source data. We keep all that information in the CDM, and that's very important to understand, because it would allow you to do any of the analytical steps that you have done on your original data, also on the CDM, because all the information is still available in the data model. So for example, one of the nice things of using a vocabulary is that you can make use of the hierarchy of the data. So of course, you could ignore vocabularies and do the same approach as been described by previous speaker, by just keeping all the individual source codes in a column in the data model. But if you would have a reference to a standardized vocabulary, you could use the hierarchy of those terminologies as well, and that's a very powerful thing. Because what we have been doing all the time in my Jerboa time is that we try to harmonize code sets over different countries, and that's a very time-consuming process to get all those individual code sets defined. What's nice about hierarchy is that you can extrapolate that information up and down the hierarchy in a very nice way, and I'll show that also for drugs, but also for conditions. Let me start with the drug example. So there are many different source vocabularies for drugs. In the Netherlands, we have Z-index, you may not have heard of, but it's a very granular coding system. But there are different coding systems in almost every country. What is great is that we can map those source codes to a standard code, in this case RX norm, which also has the granularity that we need for our studies. So all the individual things like strength and formulation are there in individual RX norm codes. And of course, and we know that, RX norm is based on US market, so it does not contain all the drugs that are on the European market. And therefore a big step is made in extending the RX norm to the European market. So we are adding all the drugs that are on the European market into that same vocabulary, which makes it very powerful. And why is it powerful? Because you can use the hierarchy, you can use different levels in the coding system to search, for example, for all drugs without looking at formulation, or all drugs without looking at the strength. We have all been using for a very long time ATC as a kind of classification level on top of that. But if you use ATC, you lose the information about strength and formulation. And by going just one level deeper in the RX norm, you can keep that information. And I think that's crucial for some of the important also drug safety studies that we want to do in Europe. For disease hierarchy, it's the same story and even nicer, I would say, because what you can do by using the vocabulary is that you can create a query on your database saying, give me all the codes on atrial fibrillation, for example. Because of the hierarchy in the system, you can now extrapolate that to all the different types of atrial fibrillation in all the different coding systems. So that means that querying a data set becomes easier. As also mentioned earlier by the previous speakers, the CDM is a tool. It's not the end goal. What we really want to do is build standardized analytics on top of our common data model. And that's something that we've been very active in. I myself, I'm leading the patient-level prediction working group together with Jenna Reps, where we built a whole pipeline on top of the CDM to do patient-level prediction. Within any cohort, you can predict an outcome using a whole bunch of machine learning algorithms and have all the different evaluation steps implemented in that framework, following our best practices. That also means that we want to stimulate open evidence. So the results that we get out of our studies, we like to share them, make them public, for example, on a website. So Odyssey is working in many different domains. And Patrick already talked a little bit about this. But we focus on clinical characterization. That's more the natural history of disease, who has diabetes, who takes a certain drug. We also do population-level effect estimation. That can be safety surveillance or comparative effectiveness studies. And patient-level prediction, the work group that I'm leading. What I really like about this is that it's a big group of active, very interested people who really like to be part of a community to develop this further. We have a lot of work group meetings within these different areas of development, and we all develop our code in open source, and that can run directly against the CDM. This also means that we have initiated many network studies using these tools against the CDM, and you can see that on the Odyssey website. I very briefly want to talk about some of the tools that are being developed in Odyssey, although there's definitely not enough time to go into detail. But as with all things, you can go to the Odyssey website and you can follow a full-day course only on this tool and on many of the other tools that we've been developing over the years. So Atlas is really the one-stop entrance of the tool sets that we are building. It has, for example, a very powerful vocabulary browsing functionality, where you can search in all the source vocabularies that are stacked up in that big concept table. You can look at the relationships of the concepts. You can search for all your ICD-9 and ICD-10 codes as well in this vocabulary, and you can see how they link up to the standardized vocabularies. This also allows us to make concept sets, as I mentioned before, in a very transparent way, and we can store these concept sets back into the system, so it becomes very clear how we created our concept sets, and we can reuse them in future studies. What Atlas also supports is complex phenotyping. As others have mentioned already today, it's not as simple as just using one code for a disease. We always talk about an algorithm for a disease that is built up of different components. So those can be conditions, drugs, procedures, measurements, etc. A diabetes definition, for example, could have a condition component, but also a drug component and a measurement component. The Atlas tool allows you to build these type of algorithms in a very interactive and nice interface. So you can make any type of complex algorithm inside Atlas. That's actually not only on the standard concept, but you can also do that on the source concepts if you want to. You can use that then to run against your database. So if you have multiple databases in-house, you can create one cohort definition, run that on the fly against your data sets, and get an attrition back on where the patients went out of the cohort on which specific rule in that complex definition. Atlas is much more than that. And unfortunately, I only have 25 minutes, and I saw already the last couple of minutes are there. But there are so many other functionalities in Atlas that I would really recommend you to have a look at. There's some very nice material about Atlas. For example, for population effect estimation, doing full propensity score model matching, doing patient level prediction, all within the tool, within your defined cohorts is a very powerful thing. What's also important to realize is that the OMOP Common Data Model is growing in Europe. The adoption of the Common Data Model in Europe is growing fast. And this is just a recent overview, but there are some ongoing initiatives, and there's actually an IMI call out there called European Health Data Network, which has as aim to map a whole lot of data sets in Europe to the OMOP Common Data Model. So that will enlarge this data network quite a lot. This is also the reason why we started a European Odyssey chapter from within Erasmus Medical Center. So there will be a meeting in March, and if you're interested in that and you want to learn more about the CDM and also discuss with all the other partners in Europe that are currently already mapping their data to the CDM, please join that, sign up through the website. The aim is, and the title reflects that, it's bridging Europe. So the idea is to have all the different groups in Europe that are currently active, which are quite a lot, give them a stage to explain what they are doing, so we can all come together and find a good way in improving the model and the vocabularies for our future use in Europe. There may be a lot of questions, and we have a little bit of panel discussion later on. What I also would like to mention is that there's a very active forum in Odyssey where you can ask your questions, and the response is very quickly. What we also did is we created a page, a frequently asked question page, because there are many questions, for example, about era definitions, use of the vocabulary. So I would recommend you to go there. It's a whole list of questions that have been worked out by people within the community. And I think that would be a very useful resource for all your future questions. And if there are more questions, post them in the forum. Thank you.
So thank you, Peter, for explaining very clearly the standardized data structures of OMOP. This could have been much more complex, and I was a bit afraid that I would not understand. But it's very, very clear, and also you explained very clearly the concept and features of OMOP, and you highlighted already some differences with Sentinel, like the hierarchical vocabularies, and the presentation of the Atlas tool was also very useful. So we will turn now on what are the challenges of applying and using these common data models in Europe, in the European environment. And our first presenter will be Olaf Klungel, who normally is on the line. Olaf, are you? I see that Olaf is not on the line. No. So we will.
Can you hear me?
Yes, are you there, Olaf?
Yes, I'm here.
Ah, good, excellent. So.
Okay.
Olaf, welcome. I will just introduce you, and then we will give you the floor. So, Olaf, you are Professor of Pharmacoepidemiological Methods and Head of the Division of Pharmacoepidemiology and Clinical Pharmacology at the University of Utrecht. You are Principal Investigator of a large number of pharmacoepidemiological studies. You participated in a number of projects at the European level, like the PROTECT project, and also you are a member of the steering group of the European Network of Centers for Pharmacoepidemiology and Pharmacovigilance concept. And you will present with your experience what are the challenges of applying common data models in the European environment. So, Olaf, I will ask you to tell when we need to go to the next slide, because probably you don't see the slide, I think. So, please tell us when we need to go to the next slides. Thank you.
All right. Do you have the first slide on? Yeah, I see the first slide. Okay. Can you still hear me?
Very well, very well.
Okay, so I'll continue. Well, thank you for the opportunity to present here at this workshop, and my apologies for not being there in person. I would very much have liked so, but I had some issues with the transportation this morning. So let's move on to the next slide.
Olaf, are you still there?
Yes, I am.
Okay, please continue then.
Okay, sorry. So next slide is my disclosure. It's here just for you to see. So please move to the next slide, which is the outline of my presentation today. So first I will give a brief overview of multi-database studies in the EU, and also a bit the evolution of these studies, and in particular how these studies have evolved in terms of harmonization of data, but also analytics. And then I will focus on specifically on the validity of analyzing multi-database studies and what kind of challenges I foresee when using a common data model. And this will involve issues around the design, but also the analysis of studies. And when thinking about the implementing a common data model for Europe, I think the main types of biases that we should be worried or maybe worried about are information and confounding bias. So those will be the biases that I will address. And then finally, some time will be spent on the analytics, how we can control for confounding in these multi-database studies. And I will conclude with some issues on reporting. Next slide, please. Okay, so this next slide shows basically what a wealth of data we have actually in Europe, and this is what data sources have been registered at the NCEP inventory of data sources. Was presented by Susana Perez at the 10th anniversary of NCEP, and a lot of different types of data sources are available. And I think we should really make most use of these data sources. Please go to the next slide. So on this slide, I want to show you a little bit the heterogeneity in terms of the data that we have in Europe. And this really is a selection of EU healthcare databases, so it's not by all means to be complete, but you see some databases from Spain, Italy, UK, Netherlands, Denmark, Germany, France. And what is striking, I think, is that there's a lot of different sources, so varying from general practitioner databases, hospital databases, claims databases, etc., but also the different coding systems that are there. Some databases have free text available where useful information may be stored, and of course this is in the national language, and so forth, so on and so forth. So I think this is something that we need to take into account when we are considering common data model for Europe. Is it really something that we can cover all of these data sources and different coding systems? Theoretically, probably we can, but I think we should also think about the implications of mapping to one common data model. Next slide, please. So this slide shows you a review of of multi-database studies that have been conducted in the EU. This was published in 2015, so some more studies have been conducted after that. So separately for the US and Canada. And for Europe, you see that in Europe, some 8 studies have been done in using data from different countries. But you also see that some countries were at that moment in time not involved at all, and some countries were very much represented, such as Italy and the UK. Next slide, please. So for this slide, I would really like to thank Mirjam Sturkenboom, who allowed me to use this slide. And I think it very nicely shows the process that we go through from developing a protocol to the final analysis and reporting. And this is what you see in the middle, in the center. So on top of this sort of arrow, you can see the different choices that we can make for each of these steps. And below, we see what the current situation is in Europe, or whether there is a consensus on such a step. So initially, I think we have a common protocol. You could choose for a separate protocol in each of the different databases, but I think most of the investigators using multiple databases for a study agree that a common protocol is very useful. Then we come to the step of getting approval for accessing data, and this is certainly not a common process or a central procedure. So this is really local, and each data partner has different approval processes that we have to overcome or to deal with. And then the step of data extraction and also data transformation. So we can do the data extraction locally, but it can also be transformed to a common data model using common scripts, central scripts, or this can also be done locally. So basically all the different models are available in the EU and being applied. So then there's a step of checking whether data is really fit for purpose. This can be done in a structured way, or less formal or no formal assessment at all. And for instance, in Protect, we spend a lot of time in checking whether the data were actually suitable for specific research questions, taking also quality parameters of the data into account, completeness of data, etc. And then the final step, the analysis and reporting, which can be local. So each center does analysis locally, or there can be one central analysis, and also making use of platforms that allow combining data at one central place. So next slide, please. So also here again, many thanks to Mirjam Sturkenboom for providing me with this slide, and there are a lot of EU projects on this slide, and I think Mirjam was in the lead of many of these. And I think it really nicely shows what the steps have been for these different projects in terms of the harmonization. So if we start on the top left, we can see that there have been many studies using a common protocol, but without a common data model, which does not mean that there has not been any harmonization. I think in these projects there was extensive harmonization of definitions of outcomes, exposures, and confounders, but it was not mapped to a common data model. This was started with, I think, in the EU ADR project with a fairly simple common data model, and then further, I think, developed in different projects. Over each project, different common data models were developed. So it's based on specific studies and specific projects. Also an important development, I think, is the different language scripting that could be used, such as Jerboa, SAS and R, and I think what's really important is that we develop these scripts in such a way that it's transparent and can be reused, and that's, I think, a step that's been taken now in most projects. Another important step was the sort of establishing a data warehouse where data or results, aggregated results, could be stored centrally and also analyzed centrally. And when we move on, I think in the advanced project, a really nice tool that was developed is the code mapper, which allows sort of semi-automatic mapping of codes and really helps in documenting how codes are mapped through the different databases. And this is something in Protect, for instance, that was, well, it took lots of time to do. So this will certainly help in conducting these multi-database studies. And finally, I think we are at the phase that OMOP Common Data Models are being tested in different projects such as EMIF, but also in another IMI project, Big Data at Heart, where CPRD data for different cardiovascular cohorts is transformed to the OMOP Common Data Model. All right, next slide, please. This brings me to sort of the next part of my presentation, but I would like to focus on the different types of biases. And first, I think really important is information bias, which means that there may be misclassification of outcomes and exposures due to loss of information in the mapping to a common data model. And the previous speaker spoke already quite a bit about that, so I think we need to be well, get into the details of what information is actually lost, but some of the possible mechanisms that we can imagine is that certain source codes are just not available in the common data model, so we cannot map them at all, or there's a different granularity in the source code. So some codes may be more granular and others may be less granular. So there may be some loss of information there, and also from free text, I think it may be difficult to completely map that to a common data model. Anyway, so regardless of the cause of this information loss, I think it may lead to bias, and probably this will be non-differential, meaning that these, for instance, misclassification of outcomes is probably independent of exposures, or vice versa, and this would lead to a underestimation of our relative risk. So in terms of detection of adverse effects, we might have less accuracy in detecting these. And I would like to show some data on analyses that we've done in Protect on the outcome of acute liver injury, and in different initiatives such as the Sentinel initiative, where ICD-9 codes were used to identify acute liver injury cases, or also in the OMOP project, many studies have been done using different codes for acute liver injury. But in Protect, we used for two databases different codes, but also laboratory tests and also free text in the Spanish BIFAP general practitioner database. Next slide, please. So what we can see in this slide is the basically how we classified acute liver injury. So we use different sources of information, so diagnostic codes, indicative of liver injury or symptoms, but also laboratory criteria such related to the elevation of liver enzymes, and also referrals to specialists or of the hospital within a few weeks of the recorded diagnosis. And what I would like to point out is that we also used in the Spanish GP database also keywords that were available in the text. Next slide, please. What we did in this project is to really validate, as far as we could, the algorithm that we developed. So for the different classifications of definite, probable, possible, and no case of acute liver injury in the Spanish database, all these cases were actually, all potential cases were manually reviewed, and all free text were considered to assess whether there was a definitely confirmed case of liver injury, probable or not confirmed. And in CPRD, we only used a sample of free text, using free text to review cases and classify them by definite or definite plus probable. Next slide, please. In this slide, it shows what the impact is of this variation in outcome definition on the rates of acute liver injury. So, we can see that I think the main point here is that if you use a quite broad definition, so definite plus probable cases of liver injury, you get a large overestimation of the actual cases of liver injury. And if you use a more narrow definition, so more precise definition, then the rates go down much more. And this is quite different actually for the Spanish GP database than for the CPRD database, where the difference is much larger. So this will have implications, I think, if we map to using different sources of information to a common data model, that will have different impacts, especially on the absolute risks of the outcomes that we study. Next slide, please. So the other important risk measure that we would like to see is, of course, the association with drugs. So this is an example of PROTECT, where we studied the outcome of liver injury associated with use of antibiotic use, using different designs, and also again these two different databases, so the CPRD GP database and the BFAP Spanish GP database. And what you can see here is that when we use a more broader definition, less accurate, that the relative risk goes down a bit, so it's attenuated. So this sort of makes the case that if there is misclassification, it's probably non-differential, but it will lead to an underestimation of the actual risk. So this is important to consider. So there is an additional error that's being included here. All right, next slide, please. The other parameter that we that we should be concerned about is, of course, the exposure. And some previous investigators have actually looked into this. So there has been some study on if there is a mapping to the OMOP Common Data Model in from CPRD, for instance, or THIN. There are some drug records that drug exposure records that cannot be mapped or are incompletely mapped. And this is, of course, some concern. We have to look into the details, what kind of drug exposures are not really mapped. And I believe in the CPRD study that was done by the Odyssey investigators, they were mainly OTC drugs. From the THIN transformation, I don't know exactly which type of drugs. It didn't really stay from the publication, but I'm sure that next speaker can provide some more details on that. So another issue, I think, what was addressed by Jeff Brown is on the complex exposure definition. So we really would need to adapt it to the specific study question and the database. So if we want to take stockpiling into account, time varying exposures, and I think we need to have the flexibility to accommodate these complex exposure definitions. Next slide, please. So the other potential source of bias that we should be worried about is confounding bias. And the impact of confounder misclassification, also again due to potential loss of information when we map to a common data model. Again, here is some data on what the amount of incomplete mapping you might have when mapping CPRD or THIN data to the OMOP Common Data Model. And this might, misclassification of confounders would lead to residual confounding because we have incompletely measured them, not accurately measured them. And so this is something we surely need to investigate. I think what the impact would be. Next slide, please. Conceptually, I think the impact would depend on the strength of the association between the confounder, so the risk factor, and the outcome, but also between the confounder and the exposure. But also, very importantly, I think the type of effect that we are studying. So if we're looking into type B adverse effects that are unpredictable and such as allergic reactions, then confounding in itself does not play such a big role compared to when we study type A adverse drug reactions which can be explained by the mechanism of action of the drug, or if we look into intended effects, so looking into comparative effectiveness, for instance, then confounding is much more an issue, and then we need to worry much more about misclassification, and this is something to consider, I think, whether a loss of information would lead to misclassification and whether confounding really is an important issue. Something to be considered, I think, is that because some information might be missing for a complete transformation to a common data model, we may consider other techniques such as multi-level, multiple imputation that has been developed for individual patient data meta-analyses, in which also from different studies, different trials, some covariates sometimes are completely lacking, so this systematic missing of information. And there are techniques to take heterogeneity between data sources into account and to actually do some multi-imputation, which we may want to do before we transform to a common data model. But this is something I think to further consider. Next slide, please. Right, so I would like to spend a few moments on the data analytical options that we have when using data, using multiple databases in a distributed data network. So the initial approach where all data is at a local level, so we can only share the fully aggregated results. In that situation, then we can meta-analyze the results to get an effect estimate. What it does allow is that we can optimize the analysis for each individual database. So we do not have to worry about variables that are not available in one database and not in the other. We can just use maximally the information available in one specific database. And then at another level of aggregation, so we could collect, and that's been done in EUDR, for instance, in carrying, but also in Sentinel, I think, to collect stratified data sets from the different databases. So these are aggregated at the level of outcomes, exposures, and some covariate patterns. So privacy is mainly preserved in these central analyses that you can then conduct. And in some situations, it is actually possible to pull data from different databases together at one place. And this has been done, for instance, in the NORPEN network, the Nordic databases. All right, next slide, please. So briefly go through the different types of analysis. So if we use the aggregate level analysis, the analysis will be mainly decentral. So each data partner is doing their own analysis. And we have many different ways of controlling for confounding, the conventional ways. But I think also different techniques can be used, such as the high dimensional propensity score, which maximally uses information from individual databases to control for confounding. And this is something that's been applied in the Canadian CNOTES network, for instance. Disease risk scores might also be considered, and these can actually be maybe valid in the different databases. And finally, distributed regression is a new technique that's under development and has also been used, I think, now. Next slide, please. What I would like to share is also that currently we're involved in a project which investigates the risk of major bleeding in patients with atrial fibrillation taking direct oral anticoagulants. This is a study that we're doing as part of the framework contract that we have with EMA, and this is basically the former PROTECT consortium. The interesting thing is that I believe that we are that this also resulted in a collaboration with CNOTES, the Canadian network, and that we're now trying to replicate findings in the CNOTES network. I think the interesting part is to consider whether the approach that we have taken now, so using a common protocol, very detailed statistical analyses and programming instructions, which has been shared with the CNOTES investigators, but without a common data model. If we would do the same exercise but using a common data model, and this is something I think for the future to investigate, and it will really help us to understand, well, what is the impact of using a common data model. Certainly it will help in speeding up, so in terms of efficiency in replicating findings. But if the results will actually be replicated, I think is something we have to see. Next slide, please. On a semi-aggregated level, data sets can be collected, stratified on outcome, exposure, and confounders. And then some central analysis can be done in which the privacy is being preserved. So confounding can be controlled if the data sets are stratified on the propensity score. And another technique that has been applied also in Sentinel is the case-centered logistic regression, where the risk sets basically are sampled from the individual databases and used in a central logistic regression. So these are interesting techniques, I think, that if we still want to be able to control for confounding in a central way, but preserving privacy, then we can deal with this if we collect data on a semi-aggregated level. Next slide, please. If we are able to do the analysis on an individual patient level, of course, then we can collect data from each of the databases and then do a central analysis. But also here we have to consider how to analyze this using a common set of confounders or utilizing the site-specific estimates. Next slide, please. So I would like to wrap up a bit, and I think in terms of conducting multi-database studies, it's really important, as for single database studies, to be clear in our reporting. So these are developments, I think. So there's a scope extension of the record statement specifically for pharmacoepidemiology to define minimum reporting requirements. Next slide, please. And more recently, also a statement that was produced by a joint working group from ISPI and ISPOR, and this is really important, I think, for database work in order to be able to reproduce and replicate findings from database studies. And if I go to the next slide, and one more. So I'm now at the slide that shows the different items to report, and I think I just wanted to point out that also in this reporting guidance, there's an item related here, mentioned under A8, that also, of course, the type of common data model, the version of the common data model, and how the data was transformed needs to be reported, and this will not always be possible in a journal paper, but certainly in a registry or online appendix. So I want to conclude. Go to the next slide, please. So to conclude, I think we need to characterize further what the loss of information might be when we transform different EU databases to a common data model, but also to assess the impact of this transformation on effect estimates from analytical studies, and some empirical studies have been done, but I think more work needs to be done to see what the impact is in different EU databases on the effect estimates. So the question we have, I think, is really, do we want a complete common data model, such as the OMOP common data model for all EU databases, or maybe some basic version where that can also be enhanced with study and database specific variables, so more like the Sentinel approach. And still, I think further developments are needed to help with the analysis of multi-database studies. in the last slide shows you some key publications. Thanks.
Thank you, Olaf. Thank you, Olaf, and thank you for reminding us core principles of pharmacoepidemiology that need to be taken into account to ensure the validity of the studies, whether they are based on common data models or not, and especially in the context of the heterogeneity of the European databases. So we will now have a presentation on a specific case and on the application of these principles on EMIF. And the presentation will be given by Johan, who is professor at Erasmus University of Medical Informatics. So, yeah. Johan, please.
Yeah. Thanks for the invitation. Let me begin by saying I feel a little bit an outsider. Do not expect intelligence comments from me with respect to pharmacovigilance or pharmacoepidemiology. That's not my turf. I come from Department of Medical Informatics, so my background is more in the area of data science in general. And if I make silly remarks about your domain, please correct me as I stand here. Outline. Hopefully catch up a little bit of time. I had prepared a few slides on scaffolding, but in the light of all the previous presentations, those slides will be extremely brief. I will make a few comments about EMIF, the project, and EMIF and a CDM, EMIF and the OMOP CDM, and then ongoing activities and challenges. Scaffolding. The most simple division we in data science make between views on information, views on data, is a division in syntactic, semantic, pragmatic. Syntax, for the sake of argument, let's say it's the grammar. The CDM itself would be on the syntactical level, it's the grammar. Semantic has to do with meaning, and pragmatic has to do with what is it in the outside world you want to influence? What's the relationship between meaning and consequences in the reality out there? And we typically layer them one after the other. Again, I'm cutting the corners, and these things are not hard, black and white. I mean, these are boundaries of gray. The CDM is on the syntactic level. The source data, I would argue, is on the bridge between syntactic and semantic. We have map data, analytical tools, and finally we move on to the pragmatic component, which is in this case is the regulatory context. One of the challenges we always face is that we need to keep these conversations in their particular domain. That is, if it is a pragmatic conversation about a regulatory context, it is probably not a discussion we should have on a CDM level. So trying to keep those discussions in their appropriate pockets is always a challenge. And there are two common diseases. I am prone to this particular disease. See, my background is a little bit in syntactic and semantic. I build tools and solutions. So therefore, I build a hammer, and therefore, I typically see the world as a collection of nails. And it remains to be seen whether my particular solution actually meets a true objective out there. I typically try to see nails where possibly there are no nails. Typically try to maybe make assumptions about the domain, the regulatory context, which are not valid. There's also a counter disease, which I have less difficulties with, but maybe others have. And that is the belief that your domain is so unique, is so specific, so extraordinary unique, that you do need special solutions, that you need constructs, information systems, syntax, grammars, which absolutely are tailored to your domain, and you're the only one. I have a few comments here this morning where people argue that quality assurance was important. From a regulatory perspective. I still have to meet a researcher who argues that quality assurance is irrelevant. Those are not characteristics of your domain which are unique to you. All people who are using real-world data worry about the quality of their data. It is possible that you might have a few different quality axes in which you want to measure it, but please articulate it then in that context. So the tunnel vision is when you believe that your domain warrants unique solutions. Also important to note that if you're an IT service provider, heaven on earth is a group of people with tunnel vision who have deep pockets to pay for it. Because the only thing you need to do is you need to fuel their awareness of their unique characteristics. And as you fuel them, they will agree that indeed they are truly unique. and as a result, you will get a bill. So one of the consequences of tunnel vision is that you become liable to very expensive exercises. The most recent one I saw in my own university, 2 years ago, we selected a new electronic healthcare record system, and I was in the selection panel. And there was long debates about how truly unique Erasmus Medical Center is. And that we had different properties, we had the regional functions. We were an academic center, not just an ordinary center, and therefore we needed a special medical record tailored to our needs. 2 years later, we are implementing a general purpose electronic record, and we've lost, I think, in the area of 15 to 20 million, around there. We learned a lot of lessons, but that could have been avoided if we would have recognized that what we share with large general hospitals is probably more than differentiates us from them. Okay, CDM, on the syntactical level. Multiple solutions are possible. Models by definition are dynamic and they will adapt themselves to the changing needs. Debate is often typically on the semantic and the pragmatic component, and that discussion in general is independent of a specific model. Therefore, the question which CDM to use is probably not the right question. You need to ask yourself different questions. Second, scaffolding. Do note that once you have addressed the semantic, the syntactic, and the pragmatic component of information, you have built yourself an information system around that. You will then make assumptions on how that system interacts with its environment. There is a clear expectation of the roles people will play. We therefore call these information systems social technical constructs. And the social part of that definition emphasizes that ingrained in that system are assumptions on who will do what. There is an understanding of context, and there's also a set of roles and responsibilities that are assigned. It's interesting to observe, for example, that our colleague from the FDA argued the notion of control. It's interesting to observe that Peter argued the notion of a community. Those are two different perspectives. They could be supported paradoxically almost by a similar information system, but they are the expectations we have about who will play what role. So much for the scaffolding. EMIF, I was told I had to talk about the experiences in EMIF. EMIF is a large IMI project. It has something like 57 partners, 14 countries. We are burning 56 million euro. The interesting thing is to observe is that this is a large diversity of data sources and a large diversity of institutions. It's a mix of hospitals, research environments, companies, SMEs, and it's multiple countries. The challenge of EMIF is to facilitate reuse of data in general. Clearly, we're interested in efficiency, in safety model. That clearly is an issue. But our agenda addresses a whole broad spectrum of domains in which we believe real-world data can be useful, ranging from discovery, development, to launch and post-launch. I do note, however, that increasingly, because we are collaborating in a number of these areas, increasingly I meet regulatory people all over the place. And I wonder a little bit what your definition of regulatory context is, because increasingly I meet also in the discovery and development phase people who are wearing a regulatory hat. But we don't have the luxury of restricting ourselves to a particular domain. The EMIF setting, data from very diverse sources. We're dealing with population-based sources, hospital-based sources. We're dealing with a number of very specific disease cohorts. In the EMIF family, we have a collection of dementia cohorts, Alzheimer cohorts. We're dealing with biobanks, diverse data. We're dealing with a broad spectrum of research questions, and the overall purpose is to facilitate the reuse of data, not for a particular application domain, but more in general. EMIF and CDM challenges. There's a clear need from EMIF's perspective for a CDM. I will not go through all the reasoning. If you want, we could discuss it later. There's a broad spectrum of coding schemes, languages, and settings available. I take heart. Was it you who said that given the US, you had more than 2 vendors, but yeah, but still, bless your heart. I mean, you have RX Norm, you have one or two coding systems, you all speak the same language, and even within that diversity you have, compare it to Europe, it's, we're living in a nightmare. We don't have a European drug register. We have to use RX norm, extend RX norm to actually get our heads around the different drugs in all the various databases. So Europe really is a quilt. It is also clear, as you're dealing with these different analytical use cases, whatever you do with a CDM, you always must escape to study-specific solutions. That there is no way out. CDM is not an alternative to study-specific solutions if they are needed. In EMIF, we emphasize a reproducible approach, open, transparent, and so on and so forth. We also emphasize the flexibility in role transfer. It is interesting to observe that in EMIF, a large number of people are collaborating, but sometimes that person is playing the role of a data provider. At other moments, he's playing the role of a study coordinator. So the roles that we play in an environment like EMIF constantly change. It's not that you have a role. Sometimes you play role A, and sometimes you play role B, and all the roles need to be able to rotate. There is no such thing in EMIF as a fixed study coordinator or a fixed center monitoring it all. And we want to support multiple technical infrastructures. EMIF and the OMOP CDM, why? As been said before, it's not a silver bullet. The CDM is not a silver bullet, but for heaven's sake, let us not develop yet another model. We have now a number of models out there. Rather than developing yet another model, let's adopt a model. In the light of the diversity of the data in the EU setting, we really like the support for standardized vocabularies in the OMOP CDM. We are not limited to specific analytical use cases. The fact that the model is tailored to regulatory purposes actually gives it, in my mind, a little bit of a red flag. It might be needed that it requires tailoring, but the fact that it's an asset, that it is restricted to regulatory purposes, okay, let's see what really is the need. I'm a fan of open source. I believe open source in general is of higher quality than closed source, but that's a different discussion. And in EMIF, we wanted to support multiple platforms. Finally, to come again to the topic of the socio-technical construct that these systems are, EMIF decided for the OMOP CDM also because of Odyssey. This notion of an open collaborative, and our observation that inside Europe there was a growing traction for the environment. So we chose for OMOP. That was not decided when we wrote the proposal. That happened along the way. What are we doing at the moment? We're mapping a number of databases to the OMOP CDM. In total 10. These are the 10 in various degrees of completion. These are, by the way, only the databases in EMIF which are being mapped. I'm aware of a number of other databases being mapped outside EMIF. The first thing we learned is that when you embark on such an ETL, you really need to build a multidisciplinary team. You need to blend the local expertise on how data is stored, recorded, and all the coding systems locally used. You need to blend that with expertise from a more EMIF orientation to actually make sure that the local expertise, which you definitely do need, is complemented by expertise on the OMOP CDM and all the tools surrounding that. For the mappings, we developed a standard pipeline. A number of people in the audience have suffered the consequences of this standardized pipeline. Maybe ask them directly. I think it works reasonably well, but the people who suffered it probably can be more straightforward. It is supported by a number of tools along the way, and an evaluation of the quality is a part of the pipeline. Recently, we presented some initial results on how the transformations went. I mean, this is work in progress. We're trying to get better at it, so this is not a final result. This was an interim report, but still a few lessons learned. One of the major requirements or major success factors for a mapping to be successful is that the source database be ready for the mapping. When we were starting the mapping in-house, I had to conclude that our own internal description of our own database was suboptimal, and you don't have to smile like that. That I was lacking here and there detailed descriptions in my data dictionary, that we actually had to go back to some of the original routines which did our own transformation in-house. The second lesson was that you do need a fair amount of project management to do this efficiently. And third lesson, most of the time you will be spending on your vocabulary mappings. You will be asked to do a significant amount of work up front in the hope that it pays off later, but that is a fairly time-consuming task. And you probably will have to time box a little bit and say that this is a limit to what I will map, and accept that not everything can be mapped, and realize that for very specific questions, you very often will have to go back to the original data anyway. Second, the first step in mapping to OMOP CDM is not mapping at all. It is importing the source data in the OMOP CDM. It's again something which I don't think people understand sufficiently. The first step is not mapping. The first step is taking up your original data and storing it in the OMOP CDM, all of it, count and see if you really have on the other side all your source data. That first stage we call the structural mapping. What you see here, and maybe this is also in response to the question that Olaf asked, because this is, if I recall correctly, thin. What you see is that if you count in the source database the number of drugs, and then you count in the OMOP version of the same database the number of prescriptions, you lose a few prescriptions. There is something lost there. You see, this is subdivided by B and F categories. So it's quite possible that once you take your source data, you move the source data without any mapping as such to the OMOP CDM, that you will have missed data. Interesting question, why does that happen? For this case, the answer is, in these source databases, we saw that prescriptions were issued before birth, and that prescriptions were issued after death, so that the fact that we lose a few prescriptions here is not necessarily bad. Is this lost in translation? Yes, but should it not be lost in translation? So step one is to move your original data, your source data, to the OMOP CDM, but maintain it as source data. And in that process, we did not encounter any structural limitations of the CDM yet. Next step is the vocabulary mapping. I think this is an issue we will revisit tomorrow at length. This is, I think, probably one of the few things which really sets the two approaches apart. This is from my own database back home. The top line, you see drugs. What you see on I can't read it myself, drugs, right? The top, how do you call it? Balk. What's the English for balk? Bar, thank you. The top bar is the terms that are being mapped, and the second bar is the data that can be mapped as a result of that mapping of terms. And what you see there, the drugs, we could only map in our first round just over 50% of the terms. That, however, accounted for more than 95% of all the prescriptions. The question is, of course, where are the other 49%? Well, one of the reasons is that we have to deal with how do you call it, when a pharmacist produces the medication on a prescription? How do you call it in English? Specialty made by the pharmacist, right? And a special. Okay. The special compounding, that's one. The second one is that in my own database, diapers are also labeled as prescriptions. Again, if you could now argue this is a poor mapping since almost 50% of the terms in my drug table could not be mapped to a common vocabulary, the counter argument is, well, maybe some of the 50% should not be mapped. So again, we have the issue of, is this losing something in translation, or is this actually removing a bit of noise? One thing we did observe is that the OMOP CDM is a US-based CDM, and it suffers the consequences and needs significant repair from a European perspective. One of the first things we needed to do is extend RX norm. I understand now that RX norm extended, European extended, is larger than the original RX norm. And I will predict there are a number of cycles we have to go through as we are extending those vocabulary. But again, remember that a vocabulary mapping is not an object of a purpose in itself. Part and parcel of the OMOP CDM exercise is that you start with the source data and that you're able to follow all the mappings and all the translations of the source data to the final data. Current CDM activities, we are replicating a number of existing EMIF use cases on the CDM. We continue to contribute to the necessary vocabulary extensions from a European perspective. We're contributing to tool development and will continue to do that. We're organizing training for stakeholders on using the CDM and the Odyssey tool. This one is mission critical from my perspective. It's good to have tools out there. It's good to have a model out there. It can only be, it absolutely requires training for people to appreciate them and to use them properly. And we are initiating and participating in the Odyssey network studies. And this is why we all started, right? This is a paper George wrote, I think a year ago, published. He did this treatment pathway study, the sunburst plots, looking at the first, second, third choice of medication in a number of domains, diabetes, hypertension, and depression. And this is from my own database. And this actually for diabetes took us 2 hours to run, from wanting to collaborate to actually having the picture ready. But that is not a fair comparison, because we could only do it in 2 hours because we spent months ahead of that trying to map and trying to get ourselves operational under the OMOP CDM. Final remarks. EMIF will continue its participation in the Odyssey network. We kicked off the Odyssey Europe chapter. We're in the process of reflecting on how we want to continue the data network after the project is finished, that is next summer. And on a more personal note, I do believe that in this type of project, but also this is a little bit independent of which particular CDM you're using, but this notion of introducing, of emphasizing our ability to replicate fast and to confirm independently is the next hurdle we face in observational research. Thank you for your attention.
Thank you, Johan, for explaining the practicalities of EMIF and also for addressing the issue of loss of information and loss of translation that is useful, because I think that many people are asking themselves this question. So let's go to the last presentation, and this is the comparison of the use of Sentinel and OMOP Common Data Models for drug safety implication for European data. This is presented by Andrew Bate, and Andrew is a senior director, analytics team lead in epidemiology at Pfizer, and he has large experience also in pharmacovigilance. He was responsible for research at the WHO Collaborating Center for International Drug Monitoring at Uppsala for 12 years. So, Andrew, you are there. Thank you.
Thank you, Xavier. Good afternoon, everyone. I'm acutely conscious that this is our last talk before the discussion, so I'll try and get through these slides relatively quickly. So before I get into it, I just want to clarify that I've been involved in OMOP. I was on the scientific advisory board of OMOP till 2013. As part of that, we participated as a member of the extended consortium of OMOP, and we did some work there on converting thin EMR into the OMOP Common Data Model with extensive help from the OMOP PI, so I'm very grateful to them. And I said Patrick was heavily involved. I should also see Christian Reich there. He was also heavily involved in helping us, guide us through some of the challenges we had with that. Also co-PI on the first IMED's now completed pilot, which is a program from non-FDA stakeholder access to the US FDA Sentinel system data and analytic tools. So I'm just going to flick through these slides quite quickly because I think these subjects have been covered extensively by other speakers, but I do think it sets up why we did the comparison study we did. We use real-world data throughout the life cycle as we try and better understand emerging safety profile of medicinal products from cohorts prior to approval, rapid query analytics capabilities, formal protocol-based assessments and hypothesis testing studies, active surveillance, and risk minimization type activities. Why is that important? Well, we use a wide range of real-world data and combinations of real-world data for real-world evidence generation. So there is no panacea. There's no one specific data or data network that we use. We need to think about the suitability of real-world data to address a given specific question of interest. We need to think about how the data captures occurred and how it's been structured. Accessibility impacts our decision-making of how we approach things. So some data sources we can bring in-house, some are distributed network access only, etc. Demonstrability of data and analysis integrity is key and I think underpins many of the discussions we're having today. And recency of data availability for analysis, as well as also thinking about the stakeholder needs. So not just how well have I done the study, but can I communicate and articulate that clearly to a given stakeholder. So we have a range of different, a smorgasbord style strategy of how we think about data. We have our in-house databases that we use extensively, sometimes with common data model based systems for rapid analysis, other times based on programming the raw data, distributed networks that we can access, and databases that we can access but we can't bring in-house, and then lastly, one-off type analyses. In the context of common data models, that means we need a range of approaches and different strategies. We've seen how a common data model type approach can be useful. I did just want to say that, and I think this point's been made, but it's interesting how the field's evolving, and it kind of triggered some of our questions. This is an analysis we did many years ago with a Harvard Pilgrim on the HMO network, looking at monitoring overtime of drug event pairs across the HMO distributed data network. It was alluded to by Olaf and others. We did some work on the OMOP Common Data Model, converting the thin EMR into the OMOP Common Data Model. It's dated in terms of the conversion. We had some trouble. It was interesting hearing the comments about the RX norm conversion. That was certainly a rate limiter for how well we could do the conversion at that point. But I think the idea of being very clear on where we have to make assumptions about conversions into a common data model is critical. Where are we able to take a code verbatim? When do we make an assumption? For example, therapy end date in the context of thin, and when is the missing data, etc. And maybe things like heat maps on top of common data models will help facilitate the end user being able to see how and where a common data model conversion is good. Just briefly mention IMEDS. I'm not going to get into any detail, but I think it's interesting. For those of you who don't know, it was built on the research methodology and the progress under Sentinel and OMOP, and it looked to advance the science further. And specifically, one of the aims was to build a process and policies around how the FDA Sentinel data and analysis tools might be accessible by a non-US FDA entity. What we did was a pilot, which is now completed. First one was around developing the policies and procedures for industry and other stakeholders to potentially access the system, and what principles that needed to be in place, what policies that needed to be there, and then to kind of test it, see how it worked. And we looked at two queries, one around assessing the effectiveness of a label change on proton pump inhibitors, and then the other one around oral contraceptives and VTE, comparing fourth and second generation. And this is now open for wider stakeholder access, and I believe it's being considered further by other groups. So, not going to talk about it in detail, but just to show the sort of outputs, and this was some of the results we got from the OCVTE. We looked at data partner variability across our outputs, and we compared fourth and generation oral contraceptives. We saw consistently higher rates of fourth generation than second generation. And if you're interested in the results, I'm very happy to discuss it offline or later. We weren't able to see which data partner was which, so they were anonymized, and that's why you see a lack of confidence intervals on the right-hand side. But we did get general statistics around the amount of variability, and certainly one of the things that was interesting for us was to see that there are some very big partners and some of the partners are much smaller, which actually explains some of the huge variability we saw in some of the data partner rates there. So given our thin common data model experience and some of the challenges we had there, and then challenges and what we learned in the context of using the Sentinel Common Data Model, how does that inform our thinking and why did it lead to the comparative study I'm going to present in a moment? Well, there are so many complications in terms of how we use common data models. We have this idea of a single validated common data model conversion per database release version, which is valuable in some way for pharmacoepidemiological research. I think we're all agreed on that, and certainly for rapid analysis, it provides this capability for fast analysis. However, in practice, we get the same database release version can be converted into different common data models, Sentinel, OMOP, PCORnet, etc. We can have different versions of the same common data model. So we have our old version of the thin OMOP common data model version. We have at least one more since then. We have, I think I've heard about potentially several CPRD common data model conversions. And then what really gets challenging is we could potentially have the same database cut with different and the same common data model version, but done by different people. So we can have, so instead of having a common data model, we can end up with an uncommon data model almost, right? So we got variations. And I think this doesn't help us in terms of credibility of the field, the amount of variability in common data model use. And then, as we've talked about today, and I'm going to talk about ecosystems in a moment, we don't just have the common data model as an entity, we have the ecosystem of tools, quality assurance, analytic procedures, etc., that run on the different common data models that themselves change over time. And then we have the changes in the database behind the common data model. So it's complicated, and that's why there has been some comparison done outside of safety, but we hadn't seen very much in the literature around CDM conversions and their impact for safety. So that's what I want to talk briefly about now. So we took a given database. In this case, we chose to work with Humana. Why do we choose Humana? Well, they were one of the extended consortium in OMOP from the beginning, and they're a Sentinel data partner. We ran a project where we looked to convert into the mini Sentinel Common Data Model at that time. So already you see this study's a bit dated. And the OMOP Common Data Model. Then we ran the mini Sentinel analytic procedures against the mini Sentinel Common Data Model and the OMOP one and generated results, and then looked to run the OMOP analytic process against the OMOP Common Data Model. And before I go any further, that was one of the great debates we had within the project team is, do we want to run the separate analytic approaches against the different common data models, or do we just want to compare the common data models? And we went forwards and backwards, and we said, well, we're going to get increase our difference in the results if we use different analytic procedures. But similarly, particularly for OMOP, which is a more common data model, the analytic tools are developed specifically for that common data model to really look at to make the most of it. And we've heard a lot about today how Sentinel is sort of as a bottom-up pragmatic solution and then has generalized as different partners have got involved, etc. Whereas OMOP tended to focus on this is the common data model and then look to see, with tweaks over time admittedly, but look to say this is the way it should be done and these are the way we need to think about tools and then how do we get our data sources into it. At least in my simplistic understanding, that's how I see the difference. So we're not being fair to the common data models if we don't look at the analytic tools that are built for each of them. So what do we look to do? Well, we look to evaluate the common data model from an ecosystem perspective to better understand how differences in the CDMs and analytics tools affect the results and the interpretation of the results potentially. We also focused on it from a signal detection rapid analysis capability perspective. Well, why do we say that explicitly in the paper? And there's a full paper you can read all of the detail. Well, we said if we're going to go from a protocol perspective, we're going to end up having this problem of we'll think about we'll basically deconstruct the common data models and the analytic tools to the point where we get identical results. So we had no doubt that you could get, if you know the database and the approaches to it, near identical results ultimately. But the idea was, what would happen if external groups did these analysis and we were comparing them, or someone was using these common data models and their tools without perhaps that much extensive understanding of it. We also focused on what was in the public domain at the time of the study initiation, and then secondary analysis looked to explain differences. So some of the differences seem very obvious post hoc, but we didn't think about them a priori, and therefore we transparently reproduced exactly what we did as far as we could and the implications of it. Just to say, we did this, Pfizer, Humana, and then we had some external experts that we picked to involve. Two names conspicuous from as lacking from that list is Jeff Brown and Patrick Ryan. We tried as far as we could to not have expertise. We tried to go, what's available, what's in the public domain, let's do this as objectively as we possibly can. That was the intent. So I showed what we did. Basically, we looked at Humana, we did the conversions, and then we ran, and analysis-wise, we looked at the CDMs and how many drugs converted into the codes, etc. Rather than run a huge number of different analyses, we focused on 6 drug event pairs. We focused on outcomes that have been well-defined and studied either in OMOP or Sentinel. So we tried to pick a range of outcomes. We chose to focus just on 2 analytic methods that have been used a lot in epidemiology. We looked at high-dimensional propensity scores and self-controlled case series, and then looked to see what we saw. So this is probably hard to follow, but basically what we did, and we found certain steps, there was more heterogeneity across the 2, but we started off with a raw Humana data. We did a CDM conversion. We looked at health outcomes. We looked at drug exposure cohorts. We looked at the pairs, and then we looked at the analysis outputs. And then once we did it, we tried to deconstruct where the differences were occurring. I'm going to flick through this slide in the interest of time. You can have the slides, and it's all in the publication anyway. But basically, there was no information loss from the Mini Sentinel Common Data Model perspective, in that we could get it all in. What was supposed to be in the Mini Sentinel Common Data Model, we could get all the Humana data in. There was some from an OMOP perspective, but it was relatively minimal. And we felt that most unmapped codes had minimal impact on our results, at least for this limited test. There were things that Humana said, well, we'd love to have put them in the common data model at the time. I don't know whether they're in the CDMs now, but they weren't then, or weren't easy for them to be found. Inpatient admission diagnosis, admission types, ICD-9 diagnosis on admission. So there was some data that Humana felt was valuable that they couldn't get into either of the common data models. And then we looked at differences in drug counts and outcomes counts. And we saw some differences here, which is quite interesting. And the most obvious one, I just highlight it here, was ketorolac. And here there was a much larger drug cohort in the OMOP Common Data Model than Sentinel. When we looked at it, it was because we just picked ketorolac and said, let's run on it. And there was all the procedure codes were pulled automatically into the OMOP Common Data Model. The Sentinel ones are in a separate table, and we didn't a priori decide to include that procedure table. So if we'd been working with Jeff Brown and his team, I'm sure he would have said, look, pull those codes. But again, then that's the role of a coordinating center potentially in terms of giving that advice on how to use a CDM appropriately, whereas within the context of OMOP, it ran and pulled them automatically. The challenge there, of course, is how well it has pulled them in, and could we really understand how well that mapping had occurred. Generally, though, we saw similar counts across the 2. Then I wanted just to give you a sense of the results. What we saw was, in general, and we looked at fixed risk periods, so 30 days post-exposure from drug initiation. We also looked variable risk period, which we defined for this study very simply as 30 days after therapy end date. And what we saw was, which surprised us, and post-hoc it didn't, but before we did the analysis, we just picked the HDPS codes that we could find. Sorry, this is self-controlled case series codes. We ran them. This was actually a custom-based self-controlled case series, so we saw, as expected, similar results. It was custom-based because at the time the Sentinel self-controlled case series wasn't available, and we made some slight alterations to the OMOP implementation at the time. But we saw similar results, which kind of supported that the CDM conversion itself had been done similarly. But when we looked at the HDPS, we saw very different results for certain drug event pairs. And specifically then, there was some similarity there, and it was, I think, driven in particular around, in this case, how they implement the analytic procedures, and specifically that there was a Cox proportional hazards regression model in the Sentinel version, and it was a logistic regression model. And we saw, when we did further analysis, some variability in terms of time-varying confounding between our drug of interest and our comparator drug. The details of all that is provided elsewhere. The real take-home from this was, if you go in and you just run the analyses, just using the codes as they are, you can get very different results. It was explicable afterwards with further analysis, but in the context of rapid analysis, with other people doing analyses across different common data models, we've thought this was worrying, that there could be this amount of variability. Now, there were clear limitations with the study. You know, we focused only on one database. It was only the administrative data from one health plan. We only looked at 6 drug outcome pairs. Comparators with drugs were chosen from established negative control references, but obviously there's some arbitrary decision-making there. We applied published health outcome definitions from the 2 different groups. And as I said, we had to use a custom self-controlled case series method. But I find it noteworthy, and I think there is a need for more of these sorts of systematic analyses. This is already quite dated. There's been major developments in both common data models since this time. But I think it shows that the principles remain. We have to be careful about doing rapid analysis to get potentially very discordant results. In this case, yes, you can explain away readily, quite quickly, why there were such differences seen, but we have to be cautious. And I think I've gone through most of that. Although, as I say, in this case, we found the actual CDM conversions were quite similar for the 2. The data is more around the ecosystem. So I'm going to just sort of try and wrap up so that we have some time for discussion. I hope I've caught up a bit of our time here. I think transparency needs to be excellent, both intra-common data model-based network, but extra common data model-based network. Yes, there may be total understanding how an analysis was conducted within a system that uses common data models, but let's make sure that it's clearly understood by experts who are not involved in the common data models. No one-size-fits-all solution for CDM-based analysis. We'll always need some data outside CDMs on occasion, and it's important we have that capability of accessing that sort of data. We can't consider a CDM in isolation. It's all about the tools and the analytics that's associated with it. And then I think we need a trusted CDM-based infrastructure for ongoing use of value and credibility and evidence generation. So yes, we did a CDM conversion of the thin CDM, but as thin changes over time, so you have to keep adapting that common data model and looking at the implications. So it's an ongoing investment. It's not one-off. And we need to include ready replicability to the maximum extent possible outside the network is a key element of it. I think data vendor participation is key. So to support and understand the importance of doing and validating a CDM conversion and conducting continual improvement to ensure the sustainable routine use of the healthcare and database systems change. So, for example, if you have a CDM expert who's now working with a given database and is with that vendor, then obviously that adds an extra layer of credibility about how that's done. But it certainly helps hugely for me when I work with a common data model version if I know the vendor is fully behind it. I think as far as possible, and I don't know how we do this and how much we can do this, but there should only be one single instance, theoretically, of a data vendor validated CDM version per database cut. So if we're all using the same UK EMR, on a given version of the database, let's all use the same CDM conversion rather than having lots of different variations. That doesn't help us. So just to wrap up, I think the Hitchhiker's Guide to the Galaxy is very useful for a lot of what we're talking about here. The answer's 42. The question is, how do we get there? What is the question? That's a key element. We need to be careful, think about carefully and appropriately constructed questions with transparency about them, and that's what's difficult to determine. We need to think about the what, why, and how of the question that led to the answer, not just the answer in isolation. The answer's the easy bit. So my very final comments. I think raw data is very valuable. I didn't put that here. I think facilitating data access and ability to conduct multiple real-world data sources in Europe is very important, and clearly common data models can play in a very important role. Trusting common data model outputs for drug safety experts who do not have interest or expertise in a given common data model is critical. We need to convince the whole community of the value and the importance of our studies and facilitating replicability. There's a need for continual efforts to keep ensuring the sustainable, reliable, and transparent platforms for these common data model systems and their associated tools. And I think that sustainability is more challenging than the one-off conversions. In a world of multiple database networks, linkage between the networks, whether conceptual or technical, as Miriam was saying earlier, I think is key. And can really facilitate credible healthcare database analyses. I'd like to see the Odyssey tools usable without using the OMOP Common Data Model. I'd like to see the Sentinel tools working easily without using the Sentinel Common Data Model. The more we can use these tools across different data, raw data, common data, different common data models, the better in terms of able to do these reproducible, replicable studies that we need to enhance trust in real-world evidence. Thank you for your time.
Many thanks, Andrew, and I would like also to thank all the speakers for keeping the time so that we have now nearly half an hour of discussion and questions. So let's start with question, and I will start that. Please state your name and before.
Speak. Okay. Christian Reich, IQVIA, company formerly known as Quintiles IMS. We have a new name in the next half year. I'm going to have to say this little phrase so everybody knows that there's a new name now. Actually, I want to say something rather than a question, and I have to, because I'm somewhat close to the whole problem of mapping of codes in the OMOP Common Data Model, and I need to once and for all in this to this audience in particular, pull the tooth of these unmapped codes. Okay, so 55% is unmapped, 10% is unmapped, 7% is unmapped. Olaf cited those studies, which are a few years old, and back then it was still OMOP, not Odyssey, and was still in a different state. It doesn't exist as a problem, let me put it this way. We talk about the drugs. If you take all, let's say, CPRD med codes and then divide by the ones that are mapped, you end up with 90%. What are the 10%? As Johan already said, syringes, bandages, diapers, glucose sticks, okay? They're not drugs, okay? Everything is mapped. We have our economic extension, which essentially is now in the European markets in France, England, Germany, going to be in Holland, and then the other outside Europe, which is not relevant here, which pretty much covers everything. You run into trouble when you do that. And by the way, it's the only place in the world where you can have this, a common framework for drugs across these markets. The markets only overlap about 50%, sometimes more, sometimes less, of any two markets in two countries have the exact same drugs, okay? The rest is different. I mean, they're similar, but it's not the same. The thing where you run into trouble are herbals, homeopathics, what else? And then, of course, these over-the-counter multivitamin drugs, with 23 vitamins in there. They change them so often that there's no chance in hell you can even try following those particular products. And I don't think it matters. Same is true for the diagnostic codes. Okay, just as an example, there are 109,000 ICD-10 CM codes. That's the American version of ICD-10. The original one is only like 17,000. The Americans added a whole lot. Of those are, before the last release in August, that's still in the work. But before that, 13 of them are not mapped. 13. One of them is exercise counseling as a diagnostic code. And the other one is, actually I have to look this up here, poisoning by drugs affecting uric acid metabolism, and then there are 12 different variants. Accidental, assault, suicidal, okay? So that's it, 13 out of 110. So just to make sure, Odyssey puts an enormous effort into the whole, takes it very seriously that we need to be able to have no information loss when we do this.
Okay, thank you for your comment. Peter, would you like to comment? Or Andrew? Or yeah, Andrew?
Yeah, no, thank you, Christian. And I did make clear that this was a dated study. At that point, there were problems with the mapping, and we talked to you and Patrick and others about it, and that's why I think it's key that people talk about when a CDM conversion was done and is date stamped, and what conversion tables were used. At that point, we could have added concept IDs ourselves. We felt as an extended consortium that wasn't our role. So absolutely. And that was kind of where I was going to. I wasn't going to be specific. But for me, as a data user, I'm much more comfortable using your version, which you're saying this is thin CDM validated OMOP conversion, knowing that you know the OMOP Odyssey conversions and validation of it, than I would be if it was done by a third person, even if they're an expert in the OMOP Odyssey Common Data Model. Because you're saying, I work for the company that's the data vendor of this database. I know the OMOP Odyssey Common Data Model. Therefore, I'm saying this is the conversion. And that helps an awful lot. I think it's more challenging if I'm working with a database. I don't think I should be doing these CDM conversions. I don't think we as a pharmaceutical company it should be routinely using it. I think it would be much better if the data vendors are doing the CDM conversions.
Yeah, I think throughout the day, one of the big problems is that we are mixing up many different things into one discussion, and that really makes my head turn red. We are mixing the fact, do we want to move to a CDM with the status of a vocabulary, which is just a dynamic thing that we can update, so that's a different discussion. Then we have presentations about the quality of running some studies, analytical tools on top of the common data model, introducing bias. That's all these points are valid, I think, but they are different discussions in the whole pipeline. In the early session of Patrick, he nicely showed that we need to look at all the individual components in that whole trajectory of doing a study, starting from the CDM, doing mappings, defining phenotypes, doing cohort definitions. Those are all individual steps that we have to discuss individually, and we're just mixing all those things into one big discussion, and I really think that's not very helpful. So I'd fully agree with Christian saying that the vocabulary discussion is actually a non-discussion. It's not a reason to not move to the CDM, because it's something we can fix. And I really think that we should put all our effort in these individual steps and then make our decision and not take it as one big lump of information.
Okay, thank you, Peter. We had another question over there, yeah.
Thank you. I'm David Van Brunt from AbbVie, and thanks for all the speakers. It was really quite helpful and instructive. I'm very curious, though. There were a lot of publications that were cited that examined the use of the data models or compared them or validated them. And it's very important, obviously, to do really good science. It's also really good that we can share it. So I'm very curious about the difference in experience that people may have had when they try to publish scientific papers, whether it's on drug or on disease, where they're simply using one of these models in the context. Is it taken up very with open arms by reviewers, or do they push back? And is there a difference between the two different models in those experiences?
Jeff, would you like to answer to that question?
So I don't know if I certainly don't know what others see. And within FDA, the focus is to generate information for FDA versus public. Publication comes second. It happens, but it's definitely not the goal. In the other projects, it's really never come up. What I hear is because our other networks that are leveraged on the Sentinel tools use the same exact data set that FDA is using. So that's the way the nature of the network is. FDA is funding the creation of the data set and funding the curation of it. Others are able to use it. So it's seen as a benefit because it's not just that we're both going to Humana, it's that it's actually the same exact data set that FDA is using at Humana, you're using at Humana. So it's been, there's a benefit of the continued use of it because you're just learning. And every time you use the source data, you're learning from it. So I've seen it on the positive side, that people seem to it gives them comfort that it's not a one-off. It's using the same source that's been used before. If that makes sense.
Sorry, a follow-up. So they are accepting that it is effectively the same thing. Nobody comes back and says, well, if you're just using Humana, why aren't you just doing a custom analysis of Humana? You're putting it through this filter. And I could imagine a reviewer potentially pushing back and saying, why did you do that? What error did it cause? Is it a barrier to disclosing the research information, I guess is.
Yeah, well, I'll add for some reason, I'm always doing big multi-site studies. So the reason that you need that model is because you're not just working at Humana. It's Humana and Optum and Aetna and these others. So once you're doing that, the model facilitates it. And now that you gave me the chance to say something else, we're often using the same tools. So the Sentinel tools are public. They can be downloaded. So in the same way, you can do that for other networks. When we're doing these multi-site studies with those Sentinel data partners using their same data set, we're using the same tools, which if you can, right? Not every study can do that, and then sometimes you write your own code. But if you can use the tools, we do.
Okay, there was a question here from Rosa Gini first, and then after.
Thank you, Xavier. I'm Rosa Gini from Tuscany, Italy. So thank you again. This I think there are some ideas that are coming repeatedly from the various participants, and I think they're very useful also for tomorrow. So I would like to ask more comments on one specific point. So my understanding is that in Sentinel, in PCORnet, and in Odyssey, there was basically a learning process with cycles that led to updating the common data model according to the need of the study or of the studies. And in the case of Sentinel, this was, if I understand, Jeff, led by FDA, basically. In the case of PCORnet, probably by the scientists or by the funders as well. That was not clear, but there was still a strong leadership. And in the case of Odyssey, it was the community itself, based probably on the research topic. So there was the expansion of the model was led by the range of the research questions that were addressed from time to time. And I think this is very useful for tomorrow also to address how that should happen in Europe, because of course that in Europe there will be specific challenges, and I think that should be the model that should be adopted probably. But with respect to this, I would also like to invite Johan to comment why. I mean, EMIF was a very nice project. The funding was not bad, and we had a lot of data sources. I'm part of the project. This is why I'm saying so. It's also my fault. And clearly, this cycle did not start. And so I'm wondering whether you can comment on that, so that we have some lessons learned.
Can I just first ask, then Lesley, because your first actually comment may be relevant, and because based on a user's perspective, what drives the development of the system?
Great question. Really, it is a combination of the funder and the scientists who are part of the network, to just be brief, so that you can get on to the next one. But sorry, I wasn't clear.
no, that was my fault, of course.
Johan, would you like to comment on this?
I don't think, Rosa, I quite understood your question. Could you rephrase? You lost me.
Yeah, I mean that I understand from the other experiences that basically starting from a scratch common data model or from previous experiences, what was felt as necessary was to conduct cycles of refinement or expansions of the common data model that was adapted to the new situation, like in PCORnet, or so that's something that I think we will need to do in Europe as well.
Yeah.
And my question is, of course, this did not happen in EMIF, regardless of huge funding and the number of data sources. So I was wondering if maybe we can also, as EMIF, try to think why this did not happen so that we can provide the others with lessons learned.
I think that the two components to your question, the first component is, and that is clearly, there is a maintenance issue, for example, in the vocabularies, and then clearly we need to find a way forward in Europe to pick up that ball. The second part is possibly we would need extensions in the structure of the CDM itself. That is possible. There are a few little corners which I think that might be candidates for that. And one of them was alluded to earlier already, when this whole notion of when are you observing somebody in an EHR environment is an exceedingly tricky one. And it pleases me greatly to hear that similar challenges are faced on both sides of the ocean. And that's one of the areas I feel that we might actually need a slight modification for. But you're correct, we need to figure out in Europe now a way to make this future-proof. Yeah, because that needs to find a home. Yeah.
Okay, thank you. Nicolas and then Steven after.
Yes, thank you for this very exciting afternoon. One small point, we're working right now on mapping the French National Pharmacovigilance Claims database, which is 66 million people, it's quite a large database, onto the Common Data Model and validating using the OMOP methodology to validate different methods to identify signals. Okay, and this is being done with the people in Boston and with the people with your team and with with Joshua and those guys and with Martin Schumi. I mean, so we're really in very good hands for that. We have a side problem we discovered last week is that when you do the same analysis on the same data set using the same programs, the same system based on a movable drive, which we change computers, we get different results when you put it in different computers. And these are not trivial differences. So we really need to work not only on the data itself, but also on the processing of the data and making sure that computers will give the same results when fed the same data. And it's the same program, the same everything, and we don't know where it comes from. Probably magic. It might be the famous Intel. No, it's because the computers might not have the same processor, and it might be related to differences
Nicholas,
in the data processor.
We have been there before, and there is something very funny going on in some very strange abbreviation of a strange number somewhere. This clearly should not happen. But how will you continue now? Which one was true?
I don't know. We're still working on it. For the moment, we're trying to duplicate this in other towns than in France, especially in Holland or in Boston.
So it's a French problem, I understand.
Because
okay, very good.
The differences are not trivial and might result in different regulatory decisions depending on what result you believe. And that is not trivial. So there is I think, an important quality issue on the validation of the results, not only of the data, but also of what comes out of the analysis, even when you use the same programs on the same data.
Okay, but we will have then tomorrow morning a session on validation. But Stephen first, yeah. And then,
yes, clearly the answer is to run it in Burgundy, where they don't make wine, is what they tell me in Bordeaux. Forgive me, when I was first a physics student, we had a lab measuring gravity. And we had stopwatches where and counting swings of a pendulum, and our stopwatches measured to essentially 1/5 of a second. And one of the students said, "This isn't accurate enough. I want one that's more accurate. And the physics lecturer said, how accurate would you like it? Well, as accurate as possible. So he was then given a stopwatch that measured to 100th of a second, and it rotated once every 3 seconds. And his answers, of course, were total rubbish, right? Because his instrument was enormously precise and very good for measuring over 3 seconds, but not very good when you realize that human reaction times are well beyond 100th, and we were actually measuring times over 30 seconds. So if you get the wrong instrument, all right, you may get extremely precise answers, as Josh Gagne said, or was quoted at the beginning. And it seems to me we have to return to the purposes of what we're trying to do. We want rapid answers. We will have to accept that they are going to be approximate, and we need to understand more clearly the limitations, including perhaps the software or the processor or somebody having the wrong default in the program. The different programs can have different defaults. And I think that we really have to return to the sort of problem that Dr. Rain mentioned. We have a situation at the moment in Europe with a treatment, radium-223, Xofigo, that in the single pivotal trial showed benefit in mortality and fractures, and it stopped early because it was so beneficial. We now have a trial that has stopped early for harm with fractures and mortality. Now, it could be that both trials got the wrong answer, but certainly at least one of them got the wrong answer. Now, if trials can do that, then so can observational data. 22 years ago, almost to the day, my Christmas was ruined by the French wanting to take the drug saligeline off the market because a trial had found an increased mortality with this drug and stopped early. Now, I then commissioned an observational study, which my friends said, you're crazy getting an observational study to confirm the results of a randomized trial. But I said, yes, that's what we should do, because it then reassured me the increase in mortality was not 50 or 60% or a doubling. It might have been 10% in the observational study, and that's what we want to do as regulators. And it seems to me that if we could, within a day or two of learning that about that randomized trial, we could have these guys give us an answer within a week to whether the observational data was showing mortality and fractures for that product in one direction or the other. As regulators, we could protect public health better. And I think that's what we should do. We mustn't argue about angels on a pinhead, all right? We must argue about trying to be aware of the limitations. There will always be limitations in observational data, and do it fast. Forgive me for whispering.
Thank you. Don.
May I underscore that, because I do believe that sometimes perfection is the enemy of progress. And how many angels can dance on the tip of a needle? Very many, typically, when we enter our own hobbies. And I do think this is clearly one of the areas where perfection is preventing progress. Yeah, I agree.
Okay, we are coming to the end of the discussion, but I will give the floor. Miriam, did you have a comment?
Yes, thank you. Thank you, Xavier. And so the discussions are very interesting, and what I'm missing, maybe just a note for tomorrow, if I may, because apparently there are at least, I think, 8 people or more or around the table here that have probably worked in multiple versions of the CDM in Europe and now have converting to OMOP. So it would be very good to hear from them. What is the added value? You know, what is it? How long does it take? Like, what are the problems? So just to get a bit more feedback on what the learnings were from those people. Like, how long does it take? Like, is it really worthwhile? Is it possible in a workshop tomorrow, in one of them?
No, I think it's a very good introduction to the workshop tomorrow. I think this discussion today was already a good warm-up for the discussion in the workshops and afterwards. And